On great. Welcome to the Health and Government Operations Committee. Please do not forward the Zoom link for the hearings. Staff will not allow anyone who was not invited to testify into the hearing. I ask you to encourage people to watch the hearing on YouTube. Bill sponsor witness timing. The bill sponsor or a designee is allowed 5 minutes to present the bill. 5 witnesses will each be allowed to speak for 2 minutes in support. We will take questions afterwards. Please stay in the hearing until the delegates have had an opportunity to ask you questions if they have them. Next, 5 witnesses will each be allowed to speak for 2 minutes in opposition and then respond to questions. Please conclude your remarks when you hear the timer ring, and Melissa Bender will let you know. Members must remain present with your video camera on during the entirety of the hearing. It is the rule. Members, please ask only one question of one witness. If you have other questions, you may follow up offline. Please use the raise hand function to indicate that you have a question. Right under the icon where it says participants, there's a little blue hand and you can raise it. If we're not done by 3:15, we will take a break approximately at 3:15. If we're not done, and we will reconvene at 3:45 so that you can have a second to stretch. The bill hearings for today are House Bill 1280, House Bill 1258, House Bill 1022, House Bill 049, House Bill 1107, House Bill 881, House Bill 1119, House Bill 1148 is actually members jointly assigned with Ways and Means. And we have House Bill 1243, and the last bill of the day is House Bill 1203. So we have a busy agenda. We welcome all of you to the committee, and we're going to get started with House Bill 1280, which is Delegate Peña-Melnick Health, Maryland Community Health and Public Safety Center of Excellence, the establishment of such a center. So before I start, I actually sent everyone a interlineated copy of the bill because the bill has changed, heavily amended, because we have worked with the Public Defender's Office, with different advocates, with the office, the governor's office, the lieutenant governor, who actually wrote a letter in support, and also the office for which this center is going to go under, the Governor's Office of Crime Prevention, Youth and Victim Services. The executive director, Mr. Houston, wrote a letter in support of it as well. So the interlineated copy is what we're working from. Please disregard the coin section, the section that deals with the network sharing part of the bill. We have amended that out. All that is in the bill is basically the center. With that in mind, I will begin my testimony, and I thank you for your patience. Good afternoon, Chairman Pendergrass and colleagues. Thank you for allowing me to present to you House Bill 1280. This bill establishes the Maryland Community Health and Public Safety Center of Excellence in the Governor's Office of the Crime Prevention, Youth and Victim Services. In November 2020, SAMHSA's Gaines Center, which is an agency with the U.S. Department of Health and Human Services, hosted the State Summit on Behavioral Health and the Justice System. It was done actually in coordination with the Commission to Study Mental Health and Behavioral Health in Maryland, which is led by the Lieutenant Governor. There were 224 people that attended. The bill is one of the recommendations that came out of this summit. It gives us an opportunity to prevent individuals with mental health illness from entry or penetrating deeper into the criminal justice system. It will help decrease admissions to jail. It will engage individuals with mental health illness in treatment as soon as possible. In Maryland, 39% of incarcerated individuals have a behavioral health disorder. As many as 7 to 10% of patrol officers' encounters involve persons with mental health disorders. Law enforcement is a crucial point of interception to divert people from the criminal justice system. However, they often lack the knowledge of services available in the community. So the purpose of this bill to create this center is the following. The center will act as the state information repository for behavioral health treatment and diversion programs related to the criminal justice system. The center will develop a strategic plan for the state of Maryland in reducing incarceration and increasing treatment of justice-involved individuals with behavioral health disorders. It will facilitate local regional planning of behavioral health systems of care, including crisis treatment related to criminal justice system. It will identify and inform stakeholders of federal funding that may assist in the achievement of the center's goal, and it will fund the following initiatives. It will fund behavioral health crisis grant, training for 9/11 operators, peer support services, behavioral health screenings, scholarship for students attending at any university, also the HBCU that are studying behavioral health and criminal justice related issues. And it will fund behavioral health in rural communities. It also, which I love, it will actually require that they hire a law enforcement coordinator, a mental health coordinator, and any other individual deemed necessary to accomplish these goals. It will monitor and analyze planning efforts for impact on racial minorities, so it has a health equity part of it as well, and it will host an annual state sequential intercept model summit. It will also facilitate sequential intercept model training, and it will provide technical assistance for the locals to implement the best practices. The center will produce a statewide model of law enforcement assisted diversion and make recommendations. It will have a work group that will look at the utilization and sharing of data. I was, as you know, in my other life, a public defender and an assistant DA. And I can tell you that many of my clients, I would be able to make a great argument, help them out, give them another chance. And then they came back. And I found that many of them had behavioral health disorders that really did not belong in the system. And the recidivism rate was so high. So the purpose of this bill is basically to come in early, to intercept early, to make sure that we keep them in the community, that we find help for them, and at every level, as if we cannot get them early, but then they are, charged, that we again try to intercept. If they're in jail, that we again try to intercept. That if they end up serving time and coming into the community, that they get the resources they need. A center like this, a center of excellence in the government office, especially because they are committed, they are supporting it, will go a long way to reduce, the number of people that are incarcerated with behavioral health because they really need to get help. I would respectfully ask a favorable report, and thank you so much for allowing me to present to you House Bill 1280. Thank you. We have next Ms. Claudia Barber. Ms. Barber, will you please get started? You have 2 minutes for your testimony.
Good afternoon, Chairman Shane Pendergrass and Vice Chair Jocelyn Payne-Melnick. My name is Claudia Barber, and I am the first Vice President of the Anne Arundel County NAACP chapter, and I am speaking on behalf of the President, Jacqueline Alsop. The Anne Arundel County NAACP wholeheartedly supports House Bill 1280 and its companion bill, Senate Bill 857. The bill creates and establishes within the Governor's Office of Crime Prevention, Youth and Victim Services a Maryland Community Health and Public Safety Center of Excellence. We applaud this and ask that you issue a favorable report on this bill. The center is to provide technical assistance to local governments for the purpose of sharing best practices across jurisdictions. It applies grants to support work-related behavioral health and justice and facilitating the distribution of resources, technical assistance, and training in best practices. The bill also includes facilitating subsequent local and regional sequential intercept model summits to establish a regional approach to community health and public safety, which includes facilitating multi-jurisdictional applications. We say thank you for this bill. We say it is long overdue. We also applaud the bill's mention of recommendations for investment in preventive services systems, including assertive community treatment, expanding housing options for justice, and finally, we strongly endorse the 5 priorities set forth in Section 13-4206. On the last page of the bill, they are behavioral health crisis grants, training for 911 operators, peer support services, behavioral health screenings, and scholarships for students who attend a Maryland HBCU. Please vote yes for House Bill 1280. Thank you.
Thank you so much for being with us today. Next, we have Ms. Cyphers.
Good afternoon, Chair
Good
Pendergrass,
afternoon.
Vice Chair Pena Melnick, and members of the committee. I'm Maura Cyphers with Compass Government Relations. I'm here on behalf of my client, the National Alliance on Mental Illness, NAMI Maryland chapter. One of NAMI's top policy priorities is diverting individuals with mental illness from the criminal justice system. NAMI fights for policies to get people help and not handcuffs. And in a mental health crisis, people with mental illness frequently encounter police rather than getting medical attention. As a result, like you heard in the bill sponsor's testimony, people with mental illnesses are overrepresented in the criminal justice system. And NAMI believes that every community should have robust crisis services for people experiencing psychiatric emergencies and to help them avoid involvement in the criminal justice system. And really what I want to focus on in this bill in particular is how excited we are about utilizing the sequential intercept model, otherwise known as SIM. I believe SAMHSA has already approved funding for expanding the state's work on SIM and the subsequent mapping that goes along with it. They helped with the Senate sponsor get an initial grant that helped host that whole summit that the bill sponsor talked about. And what SIM is, it's a framework that helps communities address diversion, and it'll help us look holistically at a community across systems, so criminal justice, behavioral health, addiction, where an individual with mental illness might come into contact with one or more of these systems. And these intercepts, you can think of them as like a juncture or a filter is, okay, this is where they're coming into contact with the system. And, ideally we do this work so we can front and load our system and we can catch people early so they're not already incarcerated. They're not already in the emergency department. And I see that I'm out of time already. So this is a great bill we strongly support, and sequential intercept mapping is really important. Thank you very much.
Thank you for your testimony and your support today. Next, we have Ms. Nsika. Ms. Sika, will you please get started?
Thank you, Madam Chair, members of the committee. I'm Ann Seacott with Public Policy Partners. Today, I'm representing the Maryland chapter of the National Council on Alcoholism and Drug Dependence, and we support House Bill 1280 with the sponsors' amendments. According to the Substance Abuse and Mental Health Service Administration, SAMHSA, the sequential intercept model helps communities identify resources and gaps in services at each of the intercept opportunities and develop local strategic action plans. NCADD hopes this Center of Excellence that the bill establishes, in collaboration with the Behavioral Health Administration, will make strong recommendations at Intercept 0, which ideally focuses on opportunities to help people with mental health and substance use disorders who are in crisis before law enforcement becomes involved. The focus of crisis services, that this committee knows very, very well, needs to be on having services available for people where they need it and when they're ready for it. These health crises must have a health care response. But as long as police show up every time someone calls for help about an overdose and they treat it as a crime scene, we will continue to lose precious people to us because people simply will not call for help. We think there are great examples in Maryland of the other intercepts as well, including the Law Enforcement Assisted Diversion Program, options for people to get treatment while they're incarcerated or at the instead of going to jail. There's a growing amount of supports on re-entry as well. So whether we are treating people inside or getting people hooked up as soon as they leave a facility, it's really going to help families and our communities. We also very much support the effort in the bill to try to address the workforce and develop a better equipped workforce in terms of responding to crises. So we ask for a favorable report on 1280. Thank you.
Thank you for your testimony today. And we have Mr. George Escobar.
Thank you so much, Vice Chair Peña-Melnick. Thank you for having me here. My name is George Escobar. I am Chief of Programs and Services at CASA, the Mid-Atlantic region's largest immigrant serving and advocacy organization with over 90,000 members. CASA offers a wide array of services, while at the same time having these members work collectively to advocate for solutions that address structural inequities. As such, on behalf of my organization and our members, I urge you to vote in favor of this bill, which would help significantly advance efforts to create effective diversion programs aimed at reducing the number of incarcerated in our state with behavioral health needs. The appalling number of individuals in our prison system with behavioral health needs is really a shameful reminder of how we have chosen to deploy our law enforcement to address situations that do not require such measures and rather call for much more strategic interventions involving our behavioral health and social service infrastructure. This bill seeks to assist those jurisdictions interested in using data and best practices to help create effective diversion programs that can address this issue. I want to point to two issues that we believe are going to be key to success if implemented properly in our community. One is working to address, as an organization that's working to address racial and ethnic disparities, we believe it's vital to encompass a racial impact analysis as proposed by the legislation. Understanding the data behind how communities of color are disproportionately impacted by current standards of practice is vital to creating an effective diversion system that is inclusive. Key to this approach will be appropriately identifying racial and ethnic backgrounds and language needs. In Maryland, we have a thriving indigenous community, for example, from Guatemala and southern Mexico that have their own racial identity, that speak their own language. It's important to serve people in their own culture and their own language. Secondly, it's an evaluation must also include criteria that evaluate standards of practice and culturally competent care. Culturally competent behavior care is essential to success of any diversion program that targets our community. There's long existing gaps in this type of care, and we see this bill as addressing those issues, and as such, we ask for a favorable report. Thank you so much.
This is the last witness for favorable. Next, we have favorable with amendments. Are there any questions for any of these witnesses? Seeing none, thank you so much for your testimony today. Next, we have favorable with amendment. We have Mr. Frazier.
Yes, good afternoon, everyone. My name is Darrell Frazier, and I am the Policy and Community Engagement Manager at the Mental Health Association of Maryland. Mental Health Association of Maryland is a nonprofit organization and advocacy that brings together consumers, family, clinicians, advocates, and concerned citizens for unified action in all aspects of mental health, mental illness, and substance abuse. HB 1280 establishes the Maryland Community Health and Public Safety Center of Excellence. This bill charges the center with furthering a sequential intersect model framework to divert individuals with serious mental illness and substance use disorders away from the criminal justice system. We support HB 1280, but would like to offer some amendments which have been accepted to ensure that the SIM model are framing from a race equity lens. According to the Bureau of Justice Statistics, 2 million adult arrests, or roughly 16.9% in the United States each year, involve people with serious mental illnesses. It's estimated that roughly 70% of youth in the juvenile justice system have mental health conditions. The SIM is a systems planning framework to improve outcomes for people with mental health and substance use needs who become involved with the criminal justice system. However, the model has never been implemented with an eye toward ensuring that the resulting strategies and policies are equitable across populations, particularly those minority populations who will be most impacted. Accordingly, we offer the following amendments to ensure the SIM is being examined and applied through a race equity lens. In sections 134201, we add definitions for race, minority, and racial impact analysis. Chronic and historic underfunding of community mental health and substance use services have placed law enforcement on the front lines of behavioral health crisis response and turned jails and prisons into the largest mental health treatment centers. We must move forward from criminalizing mental illness and begin treating it. For those reasons, we support House Bill 1280 with amendments referenced above. Thank you.
you very much for your testimony today. We appreciate it. Next, we have Ms. Charlotte Davis.
Good afternoon, Madam Vice Chair, Madam Chair, members of the committee. I'm Charlotte Davis. I'm the Executive Director of the Rural Maryland Council. We're an independent state agency located in the Maryland Department of Agriculture, and we look at a number of concerns across the state, including lack of access to health care. Rural Marylanders are on whole sicker, poorer, and older than the rest of the population. And we support this bill, the Center of Excellence under House Bill 1280, because it includes a provision about funding behavioral health in rural communities. We see a lack of services in rural Maryland for behavioral health, and we're also, several counties are medically underserved communities. So we see this as a step forward as potentially connecting those sparse services that are available and connecting them to the existing local providers. So we do think this is a step in the direction. We appreciate the sponsors' amendments to include rural. We would also suggest 2 additional amendments. One of the centers to do a strategic plan. We would suggest that as a part of that process to include a local assessment of capacity. We know across the, rural, the shore as well as Western Maryland that there are very few public facilities available in mental health and in healthcare in general. And so having that up front, I think would be helpful in moving the strategic plan forward. And also in the collaboration section, we would encourage you to include the local health improvement coalitions. Those are the local stakeholders that are going to know exactly what's happening on the ground. And we would ask that you include those as well as a part of this bill. And with that, we ask for your favorable with amendments report of House Bill 1280.
Thank you so much for your testimony today. We really appreciate it. Are there any question of this particular panel favorable with amendment? I see none. Thank you so much for coming and being with us today. Next, we have oral testimony on info. We have Ms. Catherine Gorman.
Good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. Based on the recommended changes that have been adopted, my position on this bill has changed from informational only to favorable with amendments. My name is Kate Gorman, and I'm the grant coordinator for the Justice and Mental Health Collaboration Program grant at the Office of the Public Defender in Baltimore City. In 2018, our grant team utilized the sequential intercept model to map Baltimore City's behavioral health and criminal justice systems and created a program to address the gaps we identified during the mapping. With the aim of improving connections to treatments and lowering rates of recidivism, our program identifies people with mental illness who frequently cycle through our jails on low-level charges and connects them to services in the community that better address their needs. While our program has shown early promising results, it is extremely limited in scope and resources, and it merely chips away at a more pervasive system-wide problem. Each time someone comes into contact with the criminal justice system, starting with a call to 911 through being released on parole or probation, there are collateral consequences that follow that person, in turn making their stabilization and recovery more challenging, creating barriers to employment, stable housing, and continuity of care. Mental illness and substance use disorders are health conditions that are best served through effective prevention and treatment services. Studies have found in the United States that 64% of people in local jails suffer from mental illness and 68% have a substance use disorder. We have nearly 7 times more people with mental health problems in our jails and prisons nationwide than we have in mental health treatment facilities. 911 operators, police officers, and correctional staff are routinely tasked with responding to people experiencing mental health crises, and too often they are the only ones that respond. The Center of Excellence outlined in this bill will create a centralized group of key stakeholders who are responsible for establishing and overseeing the statewide strategic planning, coordination, training, and implementation of programs aimed at diverting Marylanders with behavioral health disorders away from the criminal justice system at critical junctures. This will allow Marylanders to remain in their communities and receive the care and services they need and deserve. The Center of Excellence will work to improve systems of care that work for everyone. I ask for a favorable report. Thank you.
Thank you very much for your support. We really appreciate it. And we did take your amendments. Thank you. Next, we have Ms. Mary Piso.
There I am. Good afternoon. My name is Mary Pizzo. I'm the supervising attorney for the Forensic Mental Health Division of the Office of the Public Defender. And I originally had signed on for an informational, and I appreciate the opportunity to provide suggestions for amendments. We are changing to favorable with the amendments. We support it. This Center for Excellence, which would operate to develop models for diverting individuals with behavioral illnesses away from criminal involvement and towards the necessary treatment services. In my role as in the Forensic Mental Health Division, I consult with attorneys all over the state who have clients mired in the criminal justice system solely because they have a mental disorder driving their behavior. It is frustrating and heartbreaking to hear when a family member, believing it is the only alternative, calls the police for help in managing a mentally ill relative in crisis. Sadly, it's not uncommon for the help that results in handcuffs and charges for an assault on a police officer. A very ill individual ends up in a place least likely to be of help whatsoever. And the next professional most likely to become involved is a public defender rather than a mental health clinician. The Center for Excellence will support the development of a sequential intercept mapping system, the purpose of which is to provide alternatives to law enforcement involvement and incarceration when behavioral health alternatives provide more appropriate resolution to human problems and ultimately long-term improvement in community and safety and comfort. So the Office of the Public Defender does support House Bill 1280 with proposed amendments and requests a favorable vote. Thank you.
Thank you so much for your time and for your work in our state. Are there any questions for this particular panel? I don't see any. Thank you so much for being with us today. I want to thank Senator Esther and her staff for working with me on this bill. She's done amazing work. And this concludes the hearing on House Bill 1280. Next, colleagues, we have House Bill 1258, Delegate Kipke, Health Enterprise Zones Established Restoring the Promise Act of 2021. Good afternoon, Delegate Kipke.
Thank you, Madam Vice Chairman and Madam Chairman. It's great to be with you. This bill is a bill that I have introduced for the purposes of having a conversation and getting some information, and I plan to work on it over the interim. The genesis of the bill goes back about a decade when we raised the alcohol tax on the heels of an argument made to support folks with developmental disabilities. It was called a dime a drink. The idea was you had 10 cents to the average drink, and that money would be dedicated to the fund that supports folks with developmental disabilities. And ultimately the goal was to reduce the waiting list, which is still quite extensive in our state. The increased alcohol tax did provide for $15 million as a one-time shot in the arm to the DDA. But since then, it's flowed every year into the general fund to be used to pay for whatever is needed, but not the DDA in particular. Even with that increased sales tax on alcohol did result in lower sales of beer, wine, and spirits, and had a negative economic impact on that industry. There is being discussed right now. We had a bill heard last month that would increase the alcohol tax again to pay for some, worthy causes. But I think it's important to realize that the dollars raised by these types of things do have an impact on our economy. And I think it's most important that we make commitments that we keep, such as the one that was made with the sales tax that was increased about a decade ago. So what this bill would do is it would do everything that House Bill 463 does, which is the bill that we heard last month, but it will do it without raising taxes. I believe it's completely obvious that there are health disparities in some parts of our state, to the degree to which has become abundantly clear with COVID. And of course, we on this committee know about it better than most. We know that we really should do more. And, you know, I'm hopeful that this bill or something like it in the future is a path forward with that. I do think that raising the alcohol tax again is the wrong approach. You know, alcohol, every time we raise the alcohol tax, more beer, wine, and spirits are sold in Washington, D.C., Delaware, and it reduces the amount sold in local bars and restaurants and other places, which would be a really bad thing to do, especially right now in light of the fact that that industry has been harmed so terribly. So this legislation will take the revenue from Maryland's last increase on the alcohol tax, which averages about $90 million per year, and places part of it in a dedicated fund to fully fund a new health enterprise zone initiative in Maryland. The bill will put a minimum of $22 million per year in the Health Enterprise Zone Fund to reestablish what was a very successful program to address health disparities across our state. And it will support, the bill would support $68 million to fund reducing the waiting list for DDA services. If this were to be an ongoing fund, it would eliminate about 75% of the DDA waiting list. I know that if we were to pass this, it would have an impact on our budget, but also advocates for the DDA tell us that they would need to ramp up services because they would not have existing infrastructure to support so many new entrants into the program. So over the interim, I'll be working with the department and the advocates to determine an amount that would provide the most services for the most people based on what is currently available, as well as establishing an action plan to bring resources to areas that are currently underserved. House Bill 1258 restores the promise to underserved communities, providing needed services to address the health disparities in minority communities and prioritizing the needs of our developmentally disabled population. I appreciate your favorable consideration. Thank you, Madam Chairman.
My pleasure, Delegate Kipke. Are there any questions for Delegate Kipke? I see none. That concludes the hearing on House Bill 1258. Thank you so much for being with us. Next, we have House Bill 1022, Delegate Pendergrass. And the bill is titled Public Health, State Designated Exchange, Clinical Information. Good afternoon.
Thank you, Madam Chairman. I would like to tell you thank you all to the members for listening to this bill, and with that would like to cede my time over to Craig Bain to present the bill because he will do a better job than I would.
Thank you. Good afternoon. You can
Good
get started.
afternoon. Well, I think that was overly generous, but I appreciate that. Good afternoon, Madam Chairman, Vice Chairman. I'm Craig Bamm. I'm the Executive Director for CRISP, Maryland State Designated Health Information Exchange. First, as you all know, comprehensive data is essential to fulfilling the mission of our HIE. HB 1022 will further enable us to leverage existing connections to share broader care team information, reduce physician burden by that currently results from manual file uploads, and support public health initiatives such as combating the opioid epidemic, and prepare information for Maryland's unique total cost of care model. I mean, kind of in summary, the state's HIE functions like a utility for healthcare data. There are many contributors such as hospitals, clinics, pharmacies, payers, and even community-based organizations. This bill adds data by using existing administrative transactions through electronic health networks and reports from skilled nursing facilities. None of these groups today, the hospitals, pharmacies, or others, are paid to contribute patient information, and the HIE can only use information for specific purposes. However, by having these requirements and having these connections, we've created this unique asset for our healthcare industry. I'd like to briefly illustrate the importance of the HIE by sharing just a few of our contributions during the COVID-19 response. We used lab results to identify confirmed cases, which allowed us to notify providers and first responders when they came in contact with an infected patient. Through collaboration with the Department of Health, CRISP, the HIE is actually the starting point that triggers the contact tracing phone calls. We worked with the University System of Maryland, and we can match student lists with test information, thereby sharing a broader understanding of infections regardless of where the students were tested. Again, because we get all the lab results, we can look at statewide information. It's a really unique model. As now we all pivot to vaccinations, we're once again repurposing this shared utility to support the community. As you know, Marylanders are signing up for as many lists as possible, and then they stay on those lists even after they receive a vaccine. What CRISP is doing is getting the lists from dozens of sites, looking at hundreds of thousands of patients, and comparing them to everybody who's been vaccinated. And what we can do is tell the site that certain people don't need to be on the list anymore because they've already been vaccinated. Again, kind of reusing this centralized data utility saves critical resources and allows outreach to focus on vulnerable patients who otherwise can't get registered. And it's up to half of these lists in many cases. This is only possible because CRISP is given copies of data. If the HIE had these new feeds last year, the administrative transactions across the state from all the providers and more comprehensive nursing home data, if we had these last year, our collective public health response to COVID-19 would have been even more comprehensive. And you know, it's sad to say, I think we can be optimistic that we're coming out of this one, but for future public health responses, of which there certainly will be some, we're going to want this infrastructure in place. Many other states only have patient information that's sent through these point-to-point proprietary connections, and they can't use it for public health needs. And quite frankly, it's a waste. We've been working collaboratively on this bill for many months. We agree with the friendly amendments that have been offered by our partners at Lifespan, and we're excited to be working with Care First on some nuanced language to make it the data use is a little bit more precise. We think that's a good idea. But I'm excited about the possibilities created by this bill and ask for a favorable report. Thank you very much for your time.
Thank you so much for your testimony. And she was not being generous. You're excellent. Next, we have Mr. Ben Steffen. Mr. Steffen.
Thank you, Madam Vice Chair. Ben Steffen, Executive Director of the Maryland Healthcare Commission. I'm going to make 4 or 5 major points. As Craig has already said, this bill would require nursing homes and electronic health networks to electronically transmit clinical information to the state designated exchange. The 5 points are, CRISP has shown the technical expertise and initiative to develop new and innovative solutions. Electronic health networks and nursing homes can play a role in further seeding information that can pass through the exchange. Privacy will be protected through existing law and some additional legislation that MHCC hopes to introduce. And finally, MHCC is the essential actor in developing the regulations that that this legislation anticipates. We've demonstrated that we can bring organizations together on a level playing field and to bring a fair development of regulations that balance the needs and requirements of all participants. A bit of a word about CRISP. At the outset of the pandemic, I think there was a recognition that we would need vast amounts of new information. CRISP has demonstrated its nimbleness in providing information to the state. Craig, far better than I, has portrayed what they can do. The state recognized the importance of expanding information, and it's notable that we reached out to a variety of organizations, including large health IT organizations, other state governments in the area. And CRISP performed better than all of those. I think they can carry forward these initiatives. The Healthcare Commission is ready and willing to support those efforts as the establisher of the exchange, and the Commission encourages the committee to issue a favorable report. Thank you.
Thank you for your testimony today. We appreciate it. And next we have Mr. Davis Sharp.
Okay, Good afternoon, Madam
Good afternoon.
Chair, and to members of the committee. For the record, my name is David Sharp. I'm the Director for the Center of Health Information Technology and Innovative Care Delivery at the Maryland Healthcare Commission. As noted, this bill has two important components. The first element advances the use of electronic health information by requiring nursing homes to electronically submit clinical health information to the State Designated Health Information Exchange, CRISP. The value of health information exchange rests in the promise that more efficient access to and effective use of electronic health information can improve care delivery while reducing healthcare costs. The recognized benefits of HIE to patients and providers have not been sufficient to generate the momentum to eliminate long-standing information gaps. This bill will help ensure the availability of accurate, complete, and timely information to support high-quality care and appropriate care coordination during nursing home and hospital transfers. A second key feature of the legislation is enabling information exchange between electronic health networks and CRISP for public health purposes. Public health surveillance and monitoring are critical for alleviating or activating prevention and control to combat disease. Requiring electronic health networks to provide electronic healthcare transactions to CRISP will help Maryland expand the scope of public health surveillance. Electronic health care transactions can be used to improve the quality of public health services during investigation, contact tracing during a public health emergency, and reporting to assure cases are referred. Likewise, this information can be used to identify gaps in care and the quick remediation of those gaps before serious consequences develop for patients. HB 1022 provides for the protection of health information by limiting redisclosure of financial information, and it restricts use of information from individuals that have opted out of information sharing. It also includes restrictions on data from healthcare providers that possess sensitive health information. This bill is laudable on many levels and takes significant steps to improve patient safety and population health. Madam Chair and Vice Chair, this concludes my testimony in support for a favorable report on HB 1022.
Thank you so much for your testimony. We really appreciate it. Next, we have Ms. Robin Elliott.
Good afternoon. I'm here today on behalf of the Maryland Nurses Association, very much in support of this bill from the patient focus, which is, of course, what nurses focus on. This bill clearly helps patients when they transition from nursing homes back to their homes or other forms of care. It also helps the families, and many of you may have had this experience. I have had it with an older parent. They are discharged from the nursing home. There is a lot of information that then the family member is responsible for conveying and making sure gets to the older adults provider. This will really help eliminate that. And then therefore the nurses and other providers working with the patient can ensure that patient gets all the things that they need to hopefully live as independently as possible, whether it's OT, medically tailored meals, other primary care. This bill will really help ensure that smooth transition and ultimately benefit the patients and their families. Thank you.
Thank you for your testimony. We appreciate it. Next, we have Mr. Gene Ramson.
I apologize. My camera decided not to work today, but I assure you all I don't look any better than the last time you saw me. Just quickly, I wanted to first thank Chair Pendergrass. This is a really important public health bill, and MedChi strongly supports it. I agree with everything everyone has said, and we submitted written testimony. I'm not going to reiterate that, but I do want to talk about a really important point about this bill and why it's so important that we get it done this year. CRISP is the most successful HIE in the country, and it's an important utility for the Maryland waiver, for the all-payer contract we have, and for the goals that are outlined in the Maryland Health Plan. Included in those goals are ending disparities, working on addictions, lowering maternal mortalities, and improving the diabetes. All of those public health measures have incredible disparity issues and affect the uninsured at a higher rate. The problem is some of the private companies who might make money selling data make money not working on people who don't have insurance and not working on public health crisis, but CRISP will. And that's why we need to do this. And the folks who have concerns, in fairness, I would argue the data is owned by the patients, and the physicians are already paying a fee for the services they're getting from those companies when they pay for their EMR contracts. I think Chairman Pendergrass has it right in this bill. It gives CRISP the tools they need so we can achieve the goals in the Maryland health plan, and work towards the goals of the waiver so we can keep that important funding stream for our hospitals and the public health system in Maryland. And I really think we need to move forward with this. So I stand firmly with the nurses and the Maryland Healthcare Commission and the other proponents of this bill. This is the right thing to do, and it's going to help us work towards achieving important health outcomes around those important measures, particularly for the people who are less fortunate and aren't benefited by insurance or other means. Thank you, and I urge a favorable report on this legislation.
Thank you for your testimony today. We really appreciate it. Are there any questions for this panel of favorable? We have Delegate Lewis. Good afternoon, Delegate Lewis.
Good afternoon, Madam Chair. Thank you. Thank you for this bill, and thank you to your panelists. I am a big proponent of more and better data collection and application of data for decision making. And I'm just curious whether this bill would have helped us had it been in force during this last 12 months. Would it have helped us save lives in nursing homes by capturing information about disease outbreaks and about the vaccine rollout?
So if the other panelists don't mind, I'll take a first stab at that. I want to be kind of a little bit humble and a little bit careful to say that any single technology could have saved lives. That's not really the role of the HIE. I would say the nursing homes, through a lot of hard work and commendable effort, stood up a reporting infrastructure with CRISP during the pandemic. And in many ways, this bill codifies all the work that we did and allows it to remain in force for the next time, if there is a next time, or for the next kind of priority. So I can't say for certain that it certainly would have saved lives, but we would have had in place the thing that we built that I think has been very helpful for nursing homes and public health responders as we work through, these mobile crisis teams and different things.
Thank you, Madam Chair.
My pleasure. Any other questions for this panel? Seeing none, thank you so much for your testimony and for your help. We really appreciate it. Next, we have a favorable with amendment panel. We have Ms. Dana Kaufman. Good afternoon, Ms. Kaufman.
Thank you very much, Chair Pendermelnick and members of the committee and Chair Pendergrass. For the record, Dana Kaufman with Schwartz, Metz & Wise on behalf of Lifespan Network. Lifespan Network does support House Bill 1022. And at the onset, I do want to recognize Craig Bem and the full team at CRISP. As Mr. Bem had pointed out, over the last year, the work of CRISP has been vital to the nursing home, given the amount of reporting that was required by both the state and the federal government. Often it was overlapping information. I know that I personally spoke to Mr. Bem often, even on weekends and evenings, seeking assistance with reporting requirements and how best CRISP could work with us to help streamline that reporting process. Again, that is one of the main reasons that we support the goals of House Bill 1022, and we understand the importance of sharing information with our healthcare partners. As we have seen since the COVID-19 pandemic, coordination of care across the continuum does ensure greater outcomes. So we believe that House Bill 1022 establishes this infrastructure and will allow for greater consolidation of reporting of industry information by CRISP. And again, overall will further the state's total cost of care model. We appreciate the support for the amendments that were mentioned by CRISP. Basically, the amendments just clarify that the reporting information is to further advance public health emergencies and and outcome-driven models. So with that, we urge a favorable committee report. Thank you.
Thank you for your testimony. Are there any questions for this panel? Seeing none, that concludes the bill hearing on House Bill 1022. Thank you so much for being with us today. We appreciate it. Next, we have House Bill 849, Delegate Rosenberg, Public Health Medical Records Fees. Good afternoon, Delegate Rosenberg.
Good afternoon. Good afternoon, Madam Chair and members of the committee. House Bill 849 deals with a problem that many of us don't face, but it is a very significant problem for those who do confront it. That is the cost to gain access to certain medical records, which can be prohibitive. And the bill as amended, and the key to the bill now is the amendment, and specifically page 2 of the amendment, which provides that this prohibition on fees would apply to requests made by a patient, the patient's personal representative, or a nonprofit entity on behalf of the patient when the patient is seeking either Social Security benefits or Social Security disability payments. This can be a barrier. It should not be a barrier, and this bill would remove it, that cost as a barrier. As amended, the bill is no longer opposed and is supported. There will be testimony from both Hospital Association and from MedChi. I think that accurately and succinctly summarizes what the bill would do. And I know there is testimony from the Mental Health Association and others to provide more detail and no doubt specific instances of how this change in the law would have provided an important benefit and removed a barrier to individual patients obtaining the benefits from Social Security that they were legally entitled to. So I would urge a favorable report for this legislation as amended, as it would be amended. Thank you.
Thank you so much for your testimony today, Delegate. Next, we have Ms. Yvonne Parrott. And forgive me if I did not pronounce your name correctly.
That's quite all right, Madam Chair. Thank you. I hope I pronounced your name correctly as well. Pena Melnick.
Excellent.
Thank you.
Thank
It's
you.
correct. Thank you so much.
Yeah.
And thank you for the opportunity to present some information to you today. I'm grateful for this. I'm a licensed clinical social worker, and I serve people who are homeless and who have diagnoses of serious mental illness or co-occurring disorders. I've done this work for about 28 years and have been in social work about 40 years. I'm the founder of a program called SOAR, which stands for SSI, SSDI, Outreach, Access, and Recovery. It's a national model that it became a national model that seeks to expedite access to benefits for people, for adults who are homeless, and to help them begin their recovery and exit homelessness. SOAR exists right now in every county in Maryland, and to do this work, we need medical records. None of the SOAR trained staff does this work for profit. The folks who we train are nonprofit staff, and I do this pretty much voluntarily, although I do sometimes get paid for my time. We don't have funds to pay for medical records, and they can be quite costly. Recently, I received a bill, which may not sound like a lot, but it was $22 for records that I had canceled the request for. The $22 bill was for handling and processing. A bit ago, I received a bill for $55 for one of my folks. And clearly, the people that we're serving can't pay for these records. They have no funds. They're low income by definition. So medical records are essential for us to prove disability. And we very much need this legislation to be able to serve our most vulnerable folks in the best way we can, and to also help reduce homelessness in this state. That's the population that I'm most concerned with, although anyone applying for these benefits who needs to get their records are by definition low income and can't afford to pay for those. And so I urge a favorable report, and I thank you for your time.
Thank you so much. We really appreciate you. So next we have Ms. Kristen Urban.
Hi, good afternoon. Thank you guys for your time. My name is Kristen Urban, and I'm working as a SOAR case manager through a homeless outreach project through Prologue Inc. We're a company out in Pikesville, Maryland. So I work closely with the homeless population that live with serious mental illness, and my role is to assist them with applying with benefits, including SSDI, SSI, and TDAP, in the hopes that we can help them recover from both homelessness and their illness. At this time, our clients are unable to request their own medical records, currently as they're unable to afford the expense. And my nonprofit organization also has no budget to pay for the records. And ultimately, the medical records are essential to providing disability and also assisting in getting these resources. And this is something that they need. So, I mean, I truly believe this is a much needed piece of legislation. And I really hope we can work through this and we can help them with whatever they may need to help them get back to how they deserve to live. So thank you guys for your time. I appreciate it.
Thank you. We appreciate your testimony. Next, we have Mr. Dan Martin.
Chair Pena-Melnick, Chair Pendergrass, members of the Health and Government Operations Committee, thank you very much. For the record, Dan Martin with the Mental Health Association of Maryland. And I want to thank Delegate Rosenberg for introducing this bill. And I want to thank all the folks from the Hospital Association, from MedChi and others that worked with us on these amendments. The amendments really are important. With the amendments, with the sponsor amendments, the bill does one very simple thing. It prevents people from being charged fees for medical records that they need to access critical federal Social Security disability benefits. That's it. That's all it does. It says that if you need Social Security disability benefits, you're not going to get charged fees for medical records that you can't pay for, that you can't afford, because, like Ms. Perez said, you're by definition a disabled, low-income individual. And so it really just removes that barrier, makes sure that people that need these benefits can access them. You're going to hear you have gotten supportive written testimony from dozens of individuals and organizations. And you've heard from people on the ground like Ms. Perrette and Ms. Urban, who can tell you how helpful this is going to be. And again, I want to thank MedChi and the Hospital Association for working with us to kind of get to these amendments to make sure that everybody's on board with it. I think Ms. Witten's here and going to speak. I don't think that Mr. Steve Wise is here from MedChi, but he authorized me to say that they are supporting the bill with the amendments. So with that, I thank you very much for your time and urge a favorable report on House Bill 849.
Thank you for your testimony. Next, we have Mr. George Tolley.
Good afternoon, Madam Chair, Madam Vice Chair. My name is George Tolley. I'm here on behalf of the Maryland Association for Justice. It's always nice when we get to testify on the same side as MedChi and the Maryland Hospital Association, and I appreciate the opportunity to do so. We are very supportive of this bill as amended. We've submitted written testimony that kind of goes through the history of this statute and the amendments that were made about 5 years ago that put the fees and the cap on fees, most importantly, in place. And with the amendment, that cap on fees so that folks who aren't applying for Social Security can still get their medical records affordably, that would stay in place. And that's important to us. And because the amendment keeps that in place, we're very supportive of it and join the hospitals and the doctors in supporting Delegate Rosenberg's amended bill. And we thank him for taking the amendment. I'm happy to answer questions. Otherwise, I'll give you back the rest of my time.
Thank you so much for your testimony today. Are there any questions for this panel? There's none. Thank you so much for your testimony today. We really appreciate it. Next, we have Mr. David Weilberger.
Good afternoon, Madam Chair,
Good afternoon.
Madam Vice Chair. David Wildberger on behalf of the Maryland Association for Justice in support with amendment of this bill. And I won't take much of your time because I don't think we have anything to argue about. As the bill was initially drafted, we would have opposed it because it would have undone an agreement that was hard fought and reached back in 2015, 2016 that Madam Vice Chair may remember because she brokered the final agreement. Since it appears that all of that language is being amended out and what remains is the 4 lines on page 3, lines 17 through 20, and that's as represented to me by the Office of the Attorney General. We would wholeheartedly support the bill as amended, and I thank you very much for your time and for listening to me.
Thank you for being with us today. We have Ms. Jennifer Whitten.
Good afternoon, Madam Chair and committee members. Jennifer Whitten here representing the Maryland Hospital Association in support of House Bill 849 with the sponsor amendments. I think you heard from my colleagues. I was going to remind this committee the work we did a few years ago in reaching an agreement on adjusting some of the fees associated with medical records, but appreciate my colleagues noting that we have been in conversations with the Mental Health Association and other stakeholders and full-heartedly agree with the mission of what this bill seeks to do to ensure these individuals have the right records to apply for these benefits as they move forward in their recovery process. So we thank this committee's consideration, happy to answer any question, but we would urge a favorable report with the sponsors' amendments. Thank you.
Thank you for your testimony today. Next, we have Mr. Steve Weiss.
Steve had to testify in another committee, so he's not with us right now.
Okay, so are there any questions for this panel? Seeing none, thank you so much for being with us today. This concludes the bill hearing on House Bill 849. Next, we have House Bill 11.
Thank you.
Okay, next we have House Bill 1107, Delegate Hill, Maryland Medical Assistance Program, Supplemental Rebate Program, Subscription Model for Hepatitis C Therapies. Good afternoon, Delegate Hill.
Good afternoon. Thank you, Madam
My
Chair
pleasure.
and members of the committee. I would turn your attention, you won't see it in the floor system testimony, but my office sent around to you an amendment that we received back earlier today, which I think actually addresses all of the opposition testimony, because we've been working with folks to find out what their concerns were and to trying to address it. So I hope that as we go through the hearing, you'll reference that. So HB 1107 really seeks to fall into line with Maryland's hepatitis treatment plan by addressing one of the larger groups of folks who are at risk for hepatitis and are not all necessarily getting treatment now. So hepatitis C, as you may know, is a transmissible inflammatory disease. It's a viral infection that affects the liver, and if left untreated can progress to cirrhosis, liver failure, liver cancer, and death. It is a leading cause for liver transplants. And for every 100 people or so who are infected, about 75 to 85 people will develop chronic hepatitis C, which has other health effects. 60 to 70 of those will go on to chronic liver disease. 5 to 20 will develop cirrhosis, and another 1 to 5 liver cancer. And the best way, because it's an infectious disease, it can be transmitted through blood, so IV drug use. It can be transferred sexually. And the best way to curtail it in a population is to prevent the spread by identifying early who has it and treating those people to cure. And with current medication availability, that is possible. The problem is that the cost of the medication has been quite high. As much as $90,000 for a treatment course per patient, which right now is down to about $21,000. And if you read the the letter from MDH, they have some expectation that it may come down even further, but even so, it's pretty high. And although it is a goal of Maryland to treat and prevent this disease from spreading, the cost has been prohibitive. Now, the state has done quite a bit in dealing with treatment for hepatitis in our MCO and Medicaid population, such that patients are now covered without respect to the severity of disease, whereas up until 2 or 3 years ago, we were using severity of disease as a cutoff so that we were not treating a significant number of people because they weren't sick enough. Now everyone is available to treat if they're under Medicaid in our MCOs. And that again goes to the goal of getting rid of this infection in our population. We have not done so well with the prison population and with our general population. So what this bill would do, and again refer to the amendments, is it would essentially say, let's forget about the Medicaid folks. The bill as submitted talks about Medicaid. The amendment says take them out of it because they're being addressed. And it would say, let's take our prison population and let's take our general state covered plan employees like you and I, and let's make sure that every one of them, if they test positive for hepatitis C, can get appropriate, thorough treatment for the disease, which would help them not to go on to liver cancer and chronic liver disease, but would also prevent them from spreading it to other people. In order to do that at $21,000 a person, what we're suggesting is that we negotiate and follow a subscription model that was pioneered by Louisiana and by Washington State, where the state would contract with the various vendors who supply the medication to come up with the best price. The limitation to that model is that sometimes when they come to the best price, you're limiting to one treatment or one drug, and that won't treat everybody. And so we would sacrifice quality to get a good price. And so what the amendment also does is try and make it clear that in looking for a subscription model and the best price, we would not be looking to limit the range of treatments for the patient so the patients can get the right treatment, and that if we can't get a better price, the state would not be obligated to enter into a subscription contract. So what I'm hoping with the amendment is that we've addressed all the concerns that you'll see in the opposition and the information testimony, but we will still be really moving the state forward so that we can treat anyone with a diagnosis who's under our state plan or in our corrections thoroughly and really address our overall goal of dealing with this disease. Thank you very much.
Thank you for your testimony, Delegate. Next, we have Ms. Allison Taylor. Actually, she is providing information, so let's just stop here for a second. Are there any questions for the delegate? Will you please raise your hand under the participant icon?
I see Delegate Lewis.
I see Delegate Lewis. I don't see your hand up, but go ahead, Delegate Lewis.
Thank you, Madam Chair. I did try to raise my hand. I'm using my phone.
Okay.
So it may not
yes,
show.
Yeah, go ahead though.
Thank you so much.
My
Thank you,
pleasure.
Delegate Hill, for this really interesting bill. It seems like a state-based solution for some specialty care drugs, specifically the Hep C array of drug treatments. So that's really interesting. My question for you is, how many people in Maryland might potentially qualify under this subscription model? I think you talked about people who are incarcerated and state employees as being the population targeted for treatment. About how many people are we talking?
Yes.
Do we have an idea?
I can give you an idea just looking at the fiscal note, where it references that Medicaid treats approximately 3,200 enrollees for HCV annually. And, so that's a program. Our state prison population is smaller, so I say a fraction of that, but up to recent testing has shown that about a third of our correction inmates are hepatitis C positive.
Thank you. And I'm just wondering, until we get to the point where we have some kind of universal healthcare system, whatever that may look like, do you think this could be a reasonable stepping stone to tackling a really important and treatable, highly expensive to treat infectious disease? Is this a stepping stone, or how are you
Yes.
envisioning this?
Thank
And
you
how
for
does
the
it fit in
question.
with our and how does it fit in with what we already have, which is our the pharmacy board that we created a couple years ago?
Correct, yes. So I think that this is one way. We know, on the federal level, we've had lots of talks about how we could bring down drug prices and get appropriate treatment to people who could just negotiate, with Canada and buy drugs from other places. So this is a model that works with what we actually have now to try and bring prices down. And I would point out that, hepatitis C is rising amongst women of childbearing ages, incarcerated individuals, drug injection. And as we're seeing that population change, it has a huge effect on our overall healthcare cost. And as you said, is preventable. And it also would allow us to treat everybody and not have to have arbitrary cutoff points based on whether they're sick enough to be worth the cost of treating. So I think it's an important for our overall goal of, giving everybody the right to, a healthy existence and treatment of disease. And so, yeah, I think this is the right step. And again, I appreciate all of the folks who are testifying today, because they're the people who I spoke with to look at the original bill and say, what's wrong with this bill as I've introduced it and how can we fix it?
Thank you so much.
Thank you.
Any other questions? Seeing none, thank you very much, Delegate. Next, we have an information testimony by Ms. Allison Taylor. Good afternoon, Ms. Taylor.
Good afternoon, Madam Chair, members of the committee. My name is Allison Taylor. I'm here on behalf of Kaiser Permanente, and I want to thank Delegate Hill for meeting with me last week to discuss this bill. The comments had been prepared related to the bills introduced for Medicaid. We are one of the 9 Medicaid MCOs, but under the amendment that Delegate Hill shared, it would still be relevant to Kaiser in the sense that we provide health insurance to state employees through the state employee program. So the couple of things I wanted to note, we do provide care and coverage for these drugs at any level of disease severity currently for anyone who's a state employee, actually for anyone who has Kaiser nationwide. We negotiate these contracts nationwide, so we get the benefit of what we negotiate for the 12.5 million members that we serve. So my main concern would be if we were to move forward with something like this for the state, that we'd have the opportunity to opt out of it if it didn't seem like a better, if we Kaiser were able to negotiate a better deal than the state was. So. And to that, we'd love to be a part of the process with the, I guess it would probably be DVM that would be working on this because they administer that program. So I did receive the amendment from Delegate Hill. We'll review it, and I appreciate you sharing it, and happy to answer any questions.
Are there any questions for Ms. Taylor? I don't see, there's actually none. Thank you so much, Ms. Taylor. You have a great afternoon. And this concludes the bill hearing on House Bill 1107. Next, we have House Bill 881, Delegate Valentino Smith, Mental Health Facilities, Sexual Abuse and Harassment, Reporting and Prevention. Good afternoon, Delegate Valentino Smith. Will you get started, please? Is she here?
Did you call me? I'm sorry, I didn't hear.
Yes, it's okay.
Okay,
Good
sorry.
afternoon.
Good afternoon, popping over from budget hearings.
It's okay. Thank you for being with us. Will
Well,
you
thank you.
tell us what this bill is
Yes.
about?
Making my final appearance of my legislative career this session as my final bill. So thank you, Madam Committee. House Bill 881, with the amendments that I've sent the committee, expands, streamlines, and provides uniformity procedures for the reporting of sexual abuse in Maryland's mental health facilities, including facilities that are licensed as residential treatment centers, a state facility, or a hospital with a separately identified inpatient psychiatric service. Last year, you heard this bill. I introduced a similar bill, House Bill 1558. It had a March hearing and came to the early ending and didn't make it over. A residential treatment center is a psychiatric facility that provides campus-based intensive and extensive evaluation and treatment of children and adolescents with severe and chronic emotional disabilities. They require self-contained therapeutic, educational, and recreational program. These are very complex, very sick adult children. They are subject and more subject to sexual abuse in these treatment centers and physical abuse based on their diagnosis. And unfortunately, you remember in 2019, we had a lot of problems with the Jefferson School in Frederick. So from 2008 to 2018, Disability Rights Maryland received 47 allegations of sexual abuse from these state-operated RTCs. So I came to your committee, and in your wisdom, in 2018, we put forth House Bill 1130, which required not just state RTCs to report sexual abuse, but private RTs to support sexual abuse. And you guys passed that unanimously. So then just between 2018 and 2020, just a 2-year period, we saw an exponential number of increase of sexual abuse, 32 allegations just for the 2-year period. So it really heightened the awareness of what was happening in these centers with respect to sexual abuse. So when you have success like that, given HGO's passage of the bill in 2018, you learn a lot of information. And working with disability rights, what we've learned is that we should probably beef the statute up a little with more than just requiring reporting of abuse. By way of background, you'll remember that in 2016, there was a really large sexual abuse court case settlement, Doe versus the state of Maryland, and it required Maryland to do a lot of comprehensive changes to respond to sexual abuse in state facilities. So House Bill 881 is now coming to you because the department hasn't done everything, and the Doe settlement's going to expire, and to say that right now that they need to report, that they're going to submit the complaints to OHCQ, BHA, and Disability Rights Maryland. They're going to now be required to create policies responding to the sexual abuse complaints, which is new. Before they just had to report. Now we're going to say, create some policies. We're going to mandate that the reporting be done within 24 hours. We're going to include performing risk assessments of incoming patients to gauge the risk of any patient becoming subject or victim of sexual abuse. They're going to have to collaborate on uniform policies for reporting, and they're going to have to be able to do some plans and treatment plans in their charts. So we've submitted amendments. So as far as I know, the bill has no opponents with the amendments. We'll see a lot of positive change with the use of trauma-informed responses, proactive policies, and something I think that will overall increase the integrity of our state and private facilities. I want to point out that the fiscal note last year had no fiscal note. It said it could be done with existing resources. This year, we brought the bill to you, but we put in not just state facilities, but we put in the private facilities that treat these patients, and it caused the fiscal note to go up a little. So although we think it's good policy to apply these practices regarding sexual abuse to both public and private facilities, in order to get around the fiscal note, if it's the committee's desire to just restrict it to state facilities, we would understand that and hope that in years to come, we could work on the private facilities, or you would have to be okay with the fiscal note. And with that, I encourage a favorable report. Thank you.
Thank you for your testimony, Delegate. We have Emily Allen. Ms. Allen, good afternoon.
Good afternoon. Thank you, Madam Chair, Vice Chair, members of the committee. My name is Emily Allen. I'm from the Mental Health Association of Maryland as a public policy associate here in support of House Bill 881. The delegate did a great job of explaining the requirements in the bill. So there's just a few things that I'd like to quickly touch on. So the population that we're expanding reporting requirements for in this bill are our children and adolescents with severe and chronic emotional disabilities. Of the 6 residential treatment centers in Maryland, 1 serves children aged 5 to 13, 2 serves only boys, and the others serve adolescents and co-ed as well. In the United States, every 73 seconds, someone is sexually assaulted, and every 9 minutes, that victim is a child. We know what kinds of negative effects this childhood trauma and abuse can have on the brain and the impact it can have on that child's future. It can leave them vulnerable to further mental health issues, including depression, addiction, post-traumatic stress disorder, especially in cases where there's little parental support. Children in residential treatment centers are away from the people who can provide that support, and they're already trying to manage a severe disability. They're at these centers for help and support, and they should not have their situation made worse. Children with disabilities are at a higher risk for child sex abuse, but are less likely to receive the services and supports they need to heal and pursue justice. These changes proposed in this bill would both provide those supports and work to prevent repeated issues in the future with both themselves and other children. And for those reasons, we urge a favorable report. Thank you.
Thank you for your testimony. Next, we have Ms. Ann Geddes. Good afternoon.
Good afternoon. Thank you, Madam Chair and Madam Vice Chair. My name is Ann Geddes. I'm with the Maryland Coalition of Families. MCEF helps families that care for a loved one with behavioral health needs by providing family peer support and navigation services, and I'm here in support of House Bill 881. 881, by expanding and naming the specific entities that are to receive reports of incidents of sexual abuse and harassment, it strengthens current laws and ensures that the existing law will be better enforced, complaints will be thoroughly investigated, and strong remedial actions will be taken. House Bill 881 is needed. As was mentioned in 2019, there were very serious incidents of sexual abuse in the Jefferson School. Also in 2017, there was another private residential treatment center that was forced to close amid a variety of complaints that included allegations of sexual assault. Other less publicized incidents are not infrequent. Strong protections need to be put into place. Finally, House Bill 881 requires that preventative measures be taken by requiring residential treatment centers, state facilities, and hospitals with a separate psychiatric unit to develop treatment plans for residents that take into account their risk of being a victim of sexual or physical abuse or of being a sexual or physical abuser. Based on an individual's history, these things can be anticipated. They should be written into a resident's treatment plan. Therefore, we urge a favorable report on House Bill 881.
A little bit of problem with the button there. Thank you so much for your testimony. Next, we have Ms. Parsley. Good afternoon.
Good afternoon, Madam Chairwoman, Vice Chairwoman, members of the committee. Lucienne Parsley from Disability Rights Maryland, the legal director there. Disability Rights Maryland is the state's designated protection and advocacy organization. We are federally mandated to advance the rights of individuals with disabilities. We monitor abuse, neglect, and rights violations in Maryland's state and private psychiatric hospitals and in residential treatment centers for youth. A large portion of our mental health advocacy focuses on enforcing and reforming sexual abuse response, prevention, and treatment laws and regulations that are designed to protect children and adults with behavioral health disabilities from sexual abuse. We're here today to urge your support for House Bill 881, which strengthens sexual abuse prevention and response requirements for Maryland youth and adults. Studies consistently confirm a 50 to 80% prevalence rate of sexual and physical abuse, the history of abuse, among persons who later acquire diagnoses of mental illness. Children and adults in inpatient and institutional placements are at particular risk since they're away from family support and trusted adults. Maryland has not been immune to this problem, as you've heard. That the RTCs that were identified as having a specific large number of students involved closed in 2017 and 2020, but we still continue to receive reports. In 2016, as Delegate Valentina Smith said, we entered into a settlement agreement with the Department of Health in the Doe versus DHMH case. This House Bill 881 expands many of the policies and requirements of Doe to inpatient psychiatric facilities and youth. So we ask for your support for this bill. Thank you.
Thank you. Next, we have Rowan Powell. Good afternoon.
Good afternoon. Thank you, Madam Chair and Vice Chair and committee members for all of your hard work that you've done and are doing to improve the availability of healthcare services for Marylanders of all age. My name is Rowan Powell, and I am here providing personal testimony in support of House Bill 881. I am a survivor of childhood sexual abuse, and I believe that my story and the trauma cycle that is perpetuated is one that could have been prevented or intercepted by the mandates of this bill. In 2007, I was repeatedly sexually abused by a classmate of mine. We went to all the same classes and spent a good deal of time together in school. It started with simple demeaning comments. He called every idea I had in class stupid and reinforced that within conversations among classmates, often stating that I was worthless. He told peers that he had chosen to partner with me on projects because I was incapable of doing the work by myself. It moved from this verbal bullying to threats of violence, and then finally to actual violence. Early on, a teacher saw him punch me in the chest. She scolded him for flirting with me at school, helped me up, and as I tried to regain my breath, told me that he just liked me a lot, and that boys that age didn't know how to express their feelings correctly. After months of this escalating violence, he raped me multiple times, several of which occurred in the school building. Afterwards, my behavior changed dramatically. I stopped being a straight A student. I became withdrawn, depressed, complaining of headaches and stomach aches, and was in the nurse's office multiple times a week. Eventually, I was pulled into a guidance counselor's office due to my inability to focus or participate in class, and I disclosed to her what had been happening. I described it in the best way I could as a child, that he'd been hurting me and touching me in places that I didn't want to be touched. She kindly explained to me that what he had been doing was what boys did when they liked girls, and that perhaps I was overreacting. There were so many opportunities for intervention by an adult in my story. If my teachers or my guidance counselor had received proper training in recognizing the signs of abuse that might have been stopped after the initial verbal bullying. If they had had training, which enabled an understanding of sexual abuse between kids as young as 13 as possible, they might have intervened. And if they had received training to lay out a response protocol, which made them comfortable with reporting, intervening, I might not have been patted on the head and dismissed. The trauma of sexual assault often leads to lifelong somatic and behavioral health complications for victims, and establishing consistent care and identifying supportive services can help mitigate the damage that's done. And the oversight of protection and advocacy organizations can help coordinate the needed care throughout service transitions, especially for youth and young adults. This leads to ongoing somatic and behavioral health complications throughout one's life. It is imperative that we prepare adults to intercept this cycle of trauma. Thank you for your time, and please support House Bill 8.
Thank you, and thank you for sharing your story. We're very sorry that you had to, go through that as a young person. Anyone, for that matter, should not go through that. So we're very sorry. We do appreciate your testimony. Next, we have Charmaine Brown. Good afternoon, Ms. Brown. Charmaine Brown.
She should be in the room.
I'm here. I'm sorry. I didn't realize I had to unmute it. I'm sorry, you guys.
It's okay. It happens. Don't worry about it. How are you?
I'm fine. Thank you.
Good. Will you be so kind and get started? And you have 2 minutes. The timer is right in front of you.
Okay. So I'm here to testify in support of the House bill. I have a daughter, her name is Kalea Brown, and she has various intellectual and emotional disabilities. A little bit quickly about her background, we had moved to Maryland from Pennsylvania to try to get some support in Montgomery County to try to stabilize her. At our local care team, we were suggested that we should go to Good Shepherd over in Baltimore County because they were the best fit for her to support her needs because she likes to self-harm, her intellectual disabilities, and her past trauma. So while over there, Kalea had experienced sexual assault by peers first, and then went on to she was physically raped by a staff member. He had took her virginity while she was in a quiet room. Since then, Good Shepherd has closed down, but while there, I had been reporting her peer-related sexual assaults to her therapists and staff there, not having no outside agencies to report it to. Once she had got raped by the staff member, his name was Justin, I did report it to the police in Baltimore County, but then they went back to Good Shepherd, who basically just said that it was going to be an internal thing. I didn't have any outside support to report it to. So they basically just shoved it underneath their rug. Kalea, that facility ended up closing down. Kalea was hospitalized for 9 months, I believe, totally in Northwest from the trauma from this place. She ended up getting a center done on her and placed into another RTC. This time was at Shepherd Pratt. Again, she was sexually assaulted over there by staff members, and I reported it again to their leaders, their case managers, their therapists, and no outside entities. There was no oversight. There was no one else that we can talk to who would be able to come in and actually see that Kalea wasn't the only one in all that was going on, instead of them just handling it internally. So I think this bill is so important because it would help people like my daughter get a voice, support families, and actually bring predators to charges that do these things to prey on these vulnerable population. They do need the extra support and help. So I definitely think we all should be on board for this bill. That's it.
And thank you so much, Ms. Brown, for your testimony today. And the committee and I are very sorry that your daughter had to endure that experience. We appreciate your testimony. Next, actually, this is the end of this panel on favorable. So are there any questions from the committee for this particular panel? Next, first we have Delegate Hill. Delegate Hill.
Thank you, Madam Chair. I want to thank again the bill sponsor. She mentioned amendments, and there were also some written testimony in support with recommended amendments from Dewinder Sindhu. And I wanted to know if the sponsor could give us more details about whether her amendments address the concerns in that letter, or more specifically, what exactly her amendments do to make the bill even better.
So let me see if I can get to them. I think they have to do with a requirement.
Well, where are you making out? Because I'm bending out.
Ms. Brown, will you be so kind? And thank you so much.
Are you talking about second chance addiction cares amendment?
Yeah, so they had,
Okay,
if I may,
right,
Madam
right.
Chair.
Right. So second.
Go ahead,
So
I'm sorry.
No, thank you, Delegate Hill. So I have not been in touch with Second Chance Care, and they had not contacted my office, but obviously your staff is terrific. And when they sent out the sheet, it was the first time that I had a chance to see their conversation. And so their conversation really is about talking about substance abuse centers and not sexual and not RTCs. And so look, well, I think that it has merit to talk about substance abuse centers. We last year and this year had been focusing on the DOE settlement and sexual abuse in the RTCs. And so I would like to work with Second Chance Care over the interim to review what their concerns are with substance abuse centers. Certainly there are requirements for sexual abuse reporting that their administrators are subject to. But no, I had not, prior to seeing this, endeavored to include drug treatment centers in the bill. Wisdom of the subcommittee is the wisdom of the subcommittee on that.
Madam Chair, and follow
Yes.
up.
Just
Thank you.
very fast.
Yeah, so their other major issue was penalties. And I didn't know if it was deliberate that you're not including, or maybe in your amendment you're due, they just felt penalties were very
I
to
think what
deter behavior. Yeah.
Oh, no, the behavior needs to be deterred, there's no question. So obviously, in current law, already in the statute, it's reported to law enforcement officials. And because we're adding in OHCQ, the intention is that a facility is not running appropriately or is having a lot of these, that they're subject to the OHCQ with respect to what would be their licensing requirements and their certification requirements. So in addition to the reporting to law enforcement so that there's actual, criminal charges if the person's held responsible, but that the facility itself is going to be held responsible in its credentialing and licensing.
Thank you for speaking to it. Appreciate it. Thank you, Madam Chair.
My pleasure. Delegate Krebs.
Thank you, Madam Chair.
My pleasure.
To the bill sponsored, do you know how this bill compares to what we require now for schools, for school-age kids? I know it's very, very strict reporting of pretty much anything. And how does that follow this? It seems like it should be similar.
So, Delegate Krebs, I don't know at my fingertips the exact reporting for schools, so I can't comment on that. But what I suggest is that the schools aren't recording to OHCQ, which is what this bill is requiring these particular reports to go to. And it's requiring them to go to the state designated protection advocate, which is disability rights. And then it's requiring, because they're inpatient, that their actual chart have a plan of action and treatment, a written protection plan as part of their treatment plan and risk. So it's a little bit more health-based oriented than education-based oriented, but I don't know the specifics. I can work on.
No, I just know they're very strict about, you have to report or you get in trouble not reporting. And
you'll see in current law, there was mandatory reporting. We added into it a couple of years ago when I was in your committee for the private RTCs, and now we're adding who they have to report to, not just law enforcement.
Okay, thank you.
Thank you, Delegate. Any other questions for this panel? All right, I see none. Thank you so much for being with us today and providing your testimony. Next, we have a panel of favorable with amendment, and that is Ms. Marian Sinsel. Good afternoon.
Good afternoon. Thank you, Madam Vice Chairman, Madam Chairman, members of the committee, and particularly Delegate Valentino Smith for the invitation and opportunity to speak in support of this important bill as amended. My name is Miriam Sinsel. I'm here as a representative of Maryland Legal Aid, a nonprofit law firm providing free civil legal services to low-income and vulnerable individuals in the state of Maryland. Particularly relevant for this bill, Maryland Legal Aid attorneys represent over 2,500 children in the foster care system. Many of these children are admitted to children's inpatient mental health facilities. This bill is important for those children. They have already endured several layers of trauma in their lives, and as testified with some of the personal testimonies just now, it causes ongoing trauma to experience sexual abuse or harassment at a mental health facility where they are to receive treatment. One of our young clients was a victim of sexual trafficking before entering foster care. She was then sexually victimized by a predatory staff member at a facility. Additionally, we see this bill positively affecting adult patients at mental health facilities. Maryland Legal Aid also represents adult patients at state hospitals in forced medication cases, as well as in rights and grievance issues within the hospital. In the course of this advocacy, Maryland Legal Aid has assisted patients who have been sexually traumatized while in the facility. One felt so unsafe after an inconsistent response by the hospital that he barricaded himself in his room. This bill increases oversight and uniformity in processing and reporting abuse complaints, as well as in the victim treatment planning, thereby reducing patient trauma and preventing ongoing victimization. Its requirement of clear, consistent protocols and facilities ensures their enforcement by the designated patient advocacy entity, and particularly Maryland Legal Aid supports the amendment of a 24-hour deadline for making the reports to the appropriate outside agencies, which ensures that complaints are addressed expeditiously and efficiently. So on behalf of Maryland Legal Aid, I ask for a favorable report of House Bill 881 as amended. Thank you.
Thank you for being with us today. Are there any questions for this witness? Seeing none, Thank you so much for being with us today. Members, this concludes the bill hearing on House Bill 881. It is actually 3:12. We're going to take a break now, and we'll be back at 3:45. Next, when we return, it will be House Bill 1119, Delegate Acevedo. Thank you so much for your patience. Good afternoon, everyone. It is 3:45. Will you be so kind and put your videos on? We're going to get started. I hope you were able to stretch. So we have next House Bill 1119, and actually that is Delegate Acevedo, and it's public health, sickle cell trait, public awareness, Journey's Law. Delegate Acevedo, good afternoon. You're muted.
Good afternoon, Madam Vice Chair. Thank you very much, and to the members of the committee. For the record, Delegate Gabriel Acevedo here to present House Bill 1119, the Sickle Cell Trait Screening, Treatment, Education, and Public Awareness, or Journey's Law. Colleagues, for your edification, this bill is a reintroduction. It is named for Journey Butler, who died from renal medullary carcinoma, a rare cancer that is associated with inheriting the sickle cell gene as either from one or both parents. According to the Center for Disease Control, the CDC, as many as 1 in 10 Black babies are born with sickle cell trait. And while the sickle cell trait is found primarily in people of African ancestry, many other people, especially those from the Mediterranean, Middle East, and some parts of India, have the sickle cell trait. And so the sickle cell trait is the carrier for sickle cell disease and not the disease itself. And so when both parents carry the trait, their child or children have a 50% chance of inheriting sickle cell trait, and about a 25% chance of inheriting the actual sickle cell disease. Further, colleagues, the sickle cell trait has been linked to an increased risk of death among student athletes. As a result, the National Athletic Trainers Association recommends confirming sickle cell trait status as part of all athletes' pre-participation physical examination to address the preventable deaths stemming from it. Right here in Maryland, all newborn babies are screened for sickle cell disease, and if a baby is identified as sickle cell deficient, the state ensures that that child gets the appropriate comprehensive follow-up care. And so though screening is done at birth, many Marylanders, particularly our most vulnerable student athletes, have no idea about their sickle cell trait status, exposing them to unnecessary risk of preventable death, as we saw in the case of Journey Butler, and hence the reason for this legislation being called Journey's Law. So to this end, colleagues, when implemented, House Bill 1119, or Journey's Law, would require the Maryland Department of Health in conjunction with local health departments and the statewide steering committee on services for adults with sickle cell to develop a public awareness campaign that addresses the importance of 1, screening for sickle cell trait, 2, an individual knowing their sickle cell status, 3, an individual who carries the sickle cell trait receiving the appropriate counseling. Additionally, House Bill 1119 would empower the steering committee by requiring it to work in conjunction with members of the medical community in developing and implementing a comprehensive education and treatment program. Journey's Law supports the idea that knowledge of sickle cell trait status can be a gateway to education and can lead to the implementation of simple precautions that may prevent complications stemming from sickle cell trait. To that end, colleagues, House Bill 1119 will certainly save lives, and I urge a favorable report from this committee, and I thank you all very much for the opportunity to present House Bill 1119, or Journey's Law.
Thank you so much, Delegate, for your testimony. Are there any questions for the delegate on House Bill 1119? Seeing none, this ends the hearing on House Bill 1119. Thank you so much for being with us today, Delegate Acevedo.
Thank you so very much, Madam Vice Chair, and thank you.
Our pleasure. Next, we have House Bill 1148, Delegate Collison, Secretary of Health, School-Based Health Centers, Guidelines and Administration of Grants. Good afternoon, Delegate Collison.
Thank you, Madam Vice Chair and Madam Chair and members of the committee. Thank you very much for the opportunity to present this bill to you today. You have my written testimony where I really explain why I think this is important in terms of dealing with the health equity and disparity issues that we have in our state. I thought I would take this opportunity to respond to the letters from MSDE and MDH that we got, because I anticipate that you would have been asking about them during the questions. So I thought maybe I could let you know exactly what my response is to some of their questions and concerns prior to, since you already have my written testimony. So I'm going to start with the MSDE letter. But first, before I do that, I want to remind folks that school-based health centers are actually mini clinics inside schools. They deliver primary care service. Most of them deliver behavioral health services. Many of them deliver dental services. So these are clinics inside schools where the population is affected most by poverty. And there are 86 of them in the state right now. That's what they are. So MSDE is worried that by removing the oversight in this bill from MSDE, that it will that this completely removes their oversight. It's not the case. School-based health centers are still in school buildings. What we're giving to MDH in this bill is the ability and the authority to write the operational guidelines for the health clinics. Very important connection to make. The Department of Health, health clinics. MSDE maintains its oversight responsibilities, and we specifically asked the AG whether or not this could be done in this way, and they absolutely agreed that these two agencies could work together in this way. So it's very important to understand the relationship between the two agencies. We said that, you know, there is a mandated school health services program under that's under the purview of the school health specialist that is not related to school-based health centers. That's a different area of the statute, a different area of responsibility of MSDE, and those are the school nurses. They're not the school-based health clinics. They said that students and parents might be confused about who was responsible for the oversight. This bill does not in any way change the oversight of the school system. And so parents and students would still see the MSDE as an oversight body. They're worried about the data being breached in ways that are not appropriate. The school-based health centers are guided by HIPAA requirements, which are strong guardians and guidelines to prevent any health data from being shared. FERPA, which guards the school, which guards student data, student learning data, doesn't apply, does not a part of what the school-based health centers do. You know, the MSDE is saying that there would be less accountability and that the parents wouldn't be able to trust the school-based health centers if they felt that they were not in the purview of the schools. We haven't received a single letter of opposition to this bill. We have the support of educators, we have the support of nurses, pediatricians, and other allies who are seeking equity in education and health for our students. And I can't stress enough the relationship between health and education. Students can't learn if they're not healthy. We know, and we hear it all the time on this committee, that students who are affected by poverty are not students who are not. Now, one of the really wonderful things is that there's no fiscal note on this bill. This can be done entirely with existing resources. I looked at the letter from MDH. They in no way say that this is not an appropriate thing to do. The only thing they ask us is to reconsider the department that this would fit under in MDH. answer to that is I'm ready and willing to discuss it, but I really feel like in their rationale about shifting the burden of school-based health centers into MDH ought to be in the same area as the healthcare services. So those are the school nurses. I'm thinking it belongs in the bureau where most with children, that's maternal and child health. So with that, I'm going to turn it over to my panel to explain to you exactly what the bill does, but I hope that helps you in understanding where we are vis-a-vis the departments themselves. Thank you very much.
Thank you, Delegate. We have our first witness is Ms. Robin Elliott. Good afternoon.
Good afternoon. Robin Elliott, I'm here today on behalf of the Maryland Assembly on School-Based Healthcare, very enthusiastically in support of this bill. When we think about this move, we think about all the potential it offers school-based health centers. School-based health centers are now kind of left on the sidelines of all the excellent public health work that is being done. Many of it you all are enhancing with your health equity bills. We really feel that school-based health centers belong under the Department of Health. What Delegate Cullison's bill does, two things. First, it puts the development of policies and guidelines under the Bureau of Maternal and Child Health because school-based health centers serve children. That just seems to align. The second thing her bill does is moves the grants that go to school-based health centers from MSDE to MDH. That would happen in a year from now, because as you know, you have to work a little further out to get into the governor's budget cycle. We're very excited. We think maternal and child health is the right place to go. It offers opportunities to coordinate with the WIC program. Perhaps there could be a seamless transition from WIC to school-based health centers, coordination on immunizations, on oral health, like a dental fluoride. There's just so many opportunities here. And to us, this is the right move. School-based health centers should be part of our public health system. And we ask for a favorable report. Thank you.
Thank you for your testimony. Next, we have Ms. Tina Dove. Good afternoon.
Good afternoon, Madam Vice Chair, Madam Chair, members of the committee. My name is Tina Dove, and I'm with the Maryland State Education Association. I want to thank Delegate Cullison for introducing this. I know that she specifically, as well as Delegate Belcastro, know all too well and are all too familiar with the challenges involved with educating our babies when they're not healthy and when they are not prepared to learn. I wanted to take my opportunity with you to share some data because I think it's important for us to know really who we're talking about and the impact. So according to the Children's Health Report Card that's published by the Center for Children and Families of the Georgetown University Health Policy Institute, 48,000 children in our state were uninsured as of 2019. And I would dare say that thanks to COVID-19, those numbers have probably gone up exponentially. 3.4% of those children don't have health insurance at all in our state. And 3.8% of those kids were between the ages of 6 and 18 years of age, so school age, the kids that would benefit here. The great majority of those children that fall into that category were our children of color. They were our poor children, so they were our most vulnerable children. And the ones that were eligible for Medicaid and SCHIP, which we have the Child Health Insurance Program, the federal level of poverty at which their families are living is at a point that is challenging at best to survive in our state. So providing health care and dental care and supports to our kids in the place where we have them the most often is not just a good piece of public policy, but it is mission critical for the lives of our children. I am sad to have to remind us that we are the state that lost a 12-year-old baby in 2007 due to an abscess that was an $80 tooth extraction that could have been identified had that child gone to a school-based health clinic and had that identified by someone there. So it is for that reason and so many others that MSEA vigorously supports this legislation, and we ask for a favorable report on HB 1148. Thank you so much.
Thank you for your testimony today. Next, we have Ms. Chamoya Gardner. And I hope I pronounced your name correctly.
Perfectly.
Thank you. I practice a little.
Good afternoon, Vice Chair Benyon-Melnick, Chair Pendergrass, and members of the Health and Government Operations Committee. I am Chamoya Gardner, representing the Maryland Alliance for Racial Equity in Education, or MARIE, here in support of House Bill 1148. MARIE is a coalition of education advocacy, civil rights, and community-based organizations committed to eliminating racial disparities in Maryland's education system. We have seen at many times during the ongoing pandemic and for generations even prior to this, MSDE's poor performance on the educational welfare of Black, Brown, and Indigenous students, particularly those experiencing poverty. School-based health centers, despite their ability to transform circumstances for these very student groups, have not received the intentional investment and expansion at MSDE that could mitigate health-related disparities in educational outcomes. Our students deserve these opportunities. As an anecdote, I have seen a community school utilize their fully operational school-based health center to immunize and conduct a physical for a student who was newly enrolled, uninsured, and undocumented. These services were required for his physical attendance in class, and due to collaboration, innovation, and the vision of his community school coordinator and the staff at his school-based health center, they were able to eliminate potential weeks or months of missed educational opportunities for the student. MARIE also recognizes the threat that is always present for students of color being served by public institutions with histories and presence of betraying our communities. Our support of HB 1148 is embedded with the expectation that the staff at the Maryland Department of Health will engage in deliberative processes with impacted stakeholders, particularly Black, Brown, and Indigenous students, families, and school communities, to advance anti-racist policies and practices in service delivery, staffing, recruitment, and retention, as well as cultural competence and decision-making as related to student health care centers and the assessment of equitable outcomes. We strongly urge a favorable report on this critical legislation. Thank you.
Thank you for your testimony today. Are there questions for this panel? Delegate, one second, Delegate Krebs.
Thank you, and thank you to the bill sponsor for reading my mind and skipping the script and explaining the bill at the elementary school level. So you answered most of my questions, but it seems like after reading through the file, everyone's in favor of moving this and where it belongs. The question that's been brought up by Department of Health is, where does it actually belong that works within their work system? And I just want to know how much conversation have you had with them? Because I think there is agreement on what needs to be accomplished, but how they do it within their department is the only really outstanding issue. And have you had conversations with them about that?
I have, Delegate, not extensively. We talked when we decided to do this bill in December. I reached out to both MSDE and MDH to talk about it. And I know at that point, MDH said, are you open to discussing, where it belongs? And I said, I am. I would really want to have a thorough discussion of it, because at this point, in the letter that they sent us, they don't say that the Bureau of Maternal and Child Health is overstretched and under-resourced, whereas they're worried by putting it into, the program where they think it belongs, they would stretch their resources. So besides having the direct connection between child health and the programs that are in that bureau, the vaccination programs, the childhood asthma programs, it just all makes, to me, it's a perfect match. Like I said, I'm willing to have that discussion, and we can see where it goes. But I'm feeling, right now, I would need to be convinced that it belongs.
Well, hopefully you'll have the conversation, because you made all good points. I think it does need to move. I just want to move it where it wants to be moved to, and we'll. Thank you. Thank you.
Thank you for your question. Colleagues, we have been joined by the Ways and Means Committee. I believe we have delegates Hornberger and Delegate Guyton. I believe that's it. Yes, welcome to our committee. Next, we have Delegate Hill, followed by Delegate Riley.
Thank you very much, Madam Chair.
My pleasure.
Ellison, I love this bill. I've been wrapping my head usually in the Ways and Means Committee trying to get, public health to be primary in terms of the health we provide in the schools instead of. So I want to be clear, if this bill passes, would it have ramifications for school health outside of the school-based health centers? For instance, who holds the records for infectious disease? Who holds the records for any other health issues, even if they don't have a community-based health center? Because, obviously I think it should be, all those records should be in public health and the health department and not held primarily in the schools. Would that affect school-based health centers?
Right, this bill would not. I mean, the school-based health centers are sponsored by health agency primarily, and those are the ones who are kinds of information that you're referring to. They, but so it wouldn't affect anything outside of the school-based health centers themselves. But I think part of the potential of this bill is that we could open up the understanding around the equity issues related to health and education. I mean, it's disturbing to me that in 20 years, we only have 86 of these centers in 12 jurisdictions. And the jurisdictions where it aren't are where some of our most vulnerable kids are. And so, with, I'm hoping that with a real focus on health coming out of MDH, we'll be able to expand that and a lot more students.
Thank you so much for this bill.
Thank you. Next, we have Delegate Robin Lewis, followed by Delegate Rosenberg. Actually, I apologize. It was Delegate Riley next.
Thank you, Madam Chair, and thank you, sponsor, for this bill. Just so I have clarity on the bill, what we're doing here. So currently, the funds or the grants are under SDE. So the problem we're trying to solve is that the grants that are in the bill, they were more so currently going to educational purposes opposed to going to like the health schools?
No. Thanks for the question, because it clarify. Those grants, and it's been $2.5 million for the 20 years that the program has existed. Under the blueprint, we added $6.5 million. Those grants go towards setting up school-based health centers. So a district applies to have a school-based health center in its district, and it goes through a review process. It has to prove it has the facilities, it has to prove it has the staff, but and the sponsor, and they have to have a sponsor. So far, most of the sponsors are federally qualified health centers or local health departments, but in a bill that we passed last year, we opened that up so that hospitals could sponsor, actually groups of practitioners could sponsor a school-based health center. So these grants would go towards them to help them, establish school-based health centers in the schools where they're needed. Part of the issue is, MSDE is focused on education. I mean, that's its primary mission. And so as Robin said, it's, school-based health centers have always been like the stepchild of MSDE, and there's not a lot of energy or time, and there's no staff dedicated to it that can actually help to grow the program. And so what we're saying is MDH would have be able to do this much more efficiently because it is their mission. And it's their mission, and with all the equity bills that we've, health equity bills that we've been passing, MDH is ready and to look at ways to expand access. And this is, actually a fairly easy way to expand access to poor families and communities.
Okay, so basically, since these are school-based health centers, we think it's more appropriate for the health department through this department or agency to be able to, make the better guidelines and decisions on how we're going to proceed with our school-based health. Makes sense. Thank you.
On healthcare, right.
On healthcare, yes.
Remember,
exactly.
MSDE will still have oversight because they do live in schools.
Gotcha. Thank you.
Okay, I have next Delegate Robin Lewis. And if you have asked your question, please, if you would be so kind and lower your hand. Thank you. Robin
Thank you,
Lewis.
Madam Chair. Thank you.
My
Thank you, Delegate Cullison, for this bill. I always look forward to your school-based health bills every year. This is a good one. I'm curious, just for clarification's sake, under Kerwin, as I recall, there is a model of public school called the community school.
Mm-hmm.
We have 24 or more in Baltimore City, and maybe they exist in other places. But community schools are designated to be the home of school-based clinics, is my understanding. I just want to make sure, does this bill change that, address that? Am I mistaken?
No.
Are there just regular old public schools that will have school-based health clinics in them, or are they also designated community schools with the whole wraparound service envelope that such institutions provide?
So community schools, a community school program is a very defined program, and it's defined by the fact that it has a set of wraparound services. One of them is, I think 100%, but I can't guarantee, a health clinic center in it. So basically right now, those health centers are managed as a part of the community school program itself. So like the coordinator, but these are educationally based people. So what would happen is, as MDH became more engaged in developing guidelines and working with the staffs in the clinics in community schools, as well as other schools that are not community schools. So it doesn't change their work. I think it will add to their work. It will support their work in a better way.
Okay, great. They are kind of separate.
Yeah.
Okay, thank you so much, Madam Chair. Thank you.
My pleasure. We have next Delegate Rosenberg, followed by Delegate Hornberger. Delegate Rosenberg.
Thank you, Madam Chair. My question is either to the sponsor or to Robin Elliott. In the legislation that I introduced regarding school health centers and telehealth, we had specific language prohibiting both the Department of Health and the State Department of Education from slowing the process up in terms of applying. Was that part of the basis, or isn't that one of the factors that hopefully those kind of issues would be resolved? Those problems would be addressed by this bill, by moving the principal responsibility to the health department. That's my question.
Yeah, I'm going to take that question
Sure.
because I've been working on this for 7 years, and I know that Robin's been working on it for a long time. But I've watched over the last 7 years as we've struggled to advance the program for the issue. Primarily, like I said, the Department of Education is an education, and while it consults with the Department of Health, and the Department of Health is like, it's an add-on. It's not an integral part of the program. And so in my meetings, they're often, not on the same page. And so this, I think, will help them by creating the transition plan and understanding each other's roles very clearly. I think MSDE will be grateful to have the role that it does, because it will be limited to, making sure the space is there and, responding to parent concerns and, related to, if students can't get enrolled or whatever. But the actual clinical operation, the healthcare operation, will be managed by MDH. And so I think the bill that you introduced was a response to that kind of issue over who's in charge and what do you do next, and how do you have a healthcare discussion? Schools were shut down because of the pandemic. There was no discussion at all about the continuity of care for the students enrolled in those school-based health centers. There should have been. But again, MSDE was struggling to figure out what they were going to do with virtual education, as they should have been. And MDH was trying to figure out what they were doing with, with testing and, all of the other health issues that came about because of the pandemic. So a resource, an essential resource to the families in that community was completely eliminated for the entire, and in most districts is still not operational. So if that helps with the answer.
Thank you very much. Thank you.
Thank you. Next, we have Delegate Hornberger. Good afternoon.
Thank you, Madam Chair. And my question is more to the sort of the business case and the best use of these funds. So I'm trying to understand, is the purpose of this operation to do diagnoses, or is the purpose of this operation to do follow-on treatment, or both?
Robin, you want to take that?
So it's both. So school-based health centers provide basic primary care, so they can, help a child with school, or help them manage asthma, help them control diabetes. If there's anything complicated that needs really follow-up or specialist services, they're required to have relationships and make those referrals. Children also have primary care providers outside of the school-based health center. That's for when the school is closed. And so school-based health centers really need to be integrated into the whole healthcare system. And that's part of what this bill is doing. It'll be better integration if it's under the health department. And happy to provide more information.
Yeah, so my follow-on question, it seems like it's heavier to the diagnosis side, because at the end of the day, we don't want to create a standalone hospital at the school, for example. The bill doesn't specify that these monies need to go to opening what I'll just label as the diagnosis center to the understaffed schools, to the schools that don't currently have this. The way that I'm reading the bill is that funds could go to ones that already have an existing program for expansion. So I'm wondering why there's not language in there that specifically designates this money to go to the schools that have zero.
I can help answer that question.
Mm-hmm.
So school-based health centers have been level funded for years and years, maybe 15 or so years, with $2.5 million. So that has not been sufficient to help new school-based health centers open. So that's part of the reason why there is funding in Kerwin. And we also think by moving it to MDH, we might be able to generate tapping into some federal funding, other grant money, to do exactly what you're pointing out, which is to look at some of the jurisdictions, which is half, that do not have school-based health centers. There probably needs to be school-based health centers in every jurisdiction. These are really, really important. And to think about how to plan for them and implement that, that is a public health function, classic public health function, and done by this Maternal and Child Health Bureau. And so exactly what you're saying is part of the thinking of this bill.
Okay, so are you saying that you would?
We're only allow, Delegate, we only allow one question, and I gave you a follow-up, okay?
Okay.
So can you follow up offline with?
Yes, I'll
with
talk to the bill sponsor.
Yeah, thank you so much.
And thanks for having me. I didn't know the rules of the road over here.
No, it's like we usually read them at the beginning, and that's why, but I did give you one just because we're very kind in HGO.
Appreciate that latitude, Madam Chair. Thanks for having me.
Our pleasure. It's nice having you. Next, we have Chairman Pendergrass.
Thank you, Madam Chairman. Let me say that we did send a letter to every member of the General Assembly with the rules of our hearings, just so you know it came to your office. You might want to look at it if you're coming to visit us again. We're very happy to have you participate to the full extent that we all do. Beyond that, this is for Delegate Cullison. I believe I heard you say, please acknowledge that I'm correct, that you reached out to the health department in September as you were beginning work on this bill for this year. And that the letter that I have in my folder, the only letter I could find, is dated March 2. Was there communication? Did they respond to you in that timeframe beyond the March 2?
Thank you for the clarification. Actually, I reached out to them in December, and I had a conversation with them in December. So and the health department was very responsive. And I talked with them within one day of reaching out. They have not reached out since. So, if you're asking that, that didn't happen. And they knew, they had the language of the bill. So this was the first time I'd gotten any further information from them.
Okay, I probably misheard what you said. You probably said December, and with Zoom, I probably heard September. So thank you for that clarification and explanation that they didn't reply. The question I can't ask anyone is why they didn't continue to work with you, because there's no one here from the health department to answer that question. Thank you.
Thank you. We have Delegate Kerr.
Madam Chairman.
Yes, good afternoon.
Delegate Cullison, thanks for all your work on this bill. Now, I don't recall hearing anything from your panel. I may have missed it, but is there anything in this bill that provides additional access to mental health in these centers?
These centers almost all incorporate mental health services into them. So and you'll remember that's a huge part of the bridge to the Kerwin bill, and having those services in schools with school-based health centers has been a vital part of the work that they do. So yes, it would, if we expanded the number, as Delegate Hornberger is suggesting we should do, and I agree 100%, then there would be greater access for young people so that perhaps we could help them resolve their issues before they become real crisis kinds of situations.
Any further questions for the delegate and her panel? I don't see any. So thank you so much for being with us today. This concludes the bill hearing on House Bill 1148.
Thank you, Madam Chair.
Oh, our pleasure. And thank you, Ways and Means, for visiting with us. Welcome. Next, we have Delegate Semple Hughes, House Bill 1243, Behavior Health Services and Voluntary Placement Agreements, Children and Young Adults Report Modifications. Delegate Semple Hughes, good afternoon.
Good afternoon. Thank you, Madam Chair, for the opportunity to be in the committee to support this bill, which is House Bill 1243. This bill is, in my opinion, very important to the goals of this committee. In 2018, we passed legislation out of this committee to help understand and learn a little bit better about how the quality of mental health is given to the young people in the state of Maryland. And what we had asked for was a specific report that would help identify the gaps and what gaps needed to be filled. As many of you know, children and youth often have far fewer treatment options than adults when it comes to behavioral health care. There's been closures of residential treatment centers, such as Adventist Behavioral Health that was located in my district. More recently, you have Jefferson School in Frederick County. And so with those closures and lack of facilities available, that exacerbates the issue even more so. Additionally, there's been a decrease in the number of approved voluntary placement agreements that has continued to make life difficult for the families as they try very desperately to seek assistance. Before that bill that I just referenced that we passed in 2018, data was very hard to find to be able to share or to explain what services were available and really show that full picture. But what I am able to say today is that being we did pass that bill in 2018, we now have a full report that speaks specifically to the behavioral health services for the children and adults. I have sent a report, or excuse me, sent an email to everyone with the, if you have the interest in reading a report. So that's the good news. But what this bill today that you're hearing about is saying that we need additional information because the previous report, it did arm the advocates and our officials in the state of Maryland to really see where these underserved areas are and then help to develop policy. So to that end, it was beneficial. But again, however, this report that we're still feel that it has gaps and still needs would give us additional information such as telehealth services that may be available for the youth, certain substance use disorders services. And the other thing that we're wanting to do by way of expansion is to really look at the demographic breakdown. And so we can look at the analysis of racial and ethnic disparities. In my quick review of the report that was, required in 2018, on page 12, it speaks to the residential treatment centers in Maryland and shows that males are usually more likely to go to those facilities versus females. It breaks down some information that we wanted to know about the psychological assessments that are done. And so, but it's not enough. So this bill today, House Bill 1243, would help us in that effort to get the information and close some of those gaps. And you'll also know that there isn't going to be any additional cost to do this. According to the fiscal note, it will be done within the existing resources at the Department of Health. So for those reasons, I just want to make sure we have the proper information and help improve the lives of our Maryland's children that are in need of behavioral health services. And I ask for a favorable report on House Bill 1243. Thank you for your time and thank you, Madam Chair.
My pleasure. Thank you for your testimony. The next witness we have is Margot Quinlan. Good afternoon.
Great. Thank you, Vice Chair, Madam Chairman, and members of the committee. My name is Margot Quinlan. My pronouns are she and her. I am with the Mental Health Association of Maryland. I'm the Director of Youth and Older Adult Policy. And we are here in support of House Bill 1243, which, as the delegate said, is really building off of Delegate Sample Hughes' 2018 bill, which has initiated these reports and really begun to provide us with some pretty critical data on behavioral health services for Maryland's children and youth. But as we've begun looking at the data from these reports, we've really kind of collectively noticed that these gaps do remain. And so this bill would expand the Behavioral Health Administration report to include some pretty important expanded information about substance use disorders, utilization rates of telehealth for children's behavioral health, and then perhaps most importantly, this piece around disaggregated data on race and ethnicity. And we believe that expanding the reports to disaggregate that data will help the state, will help advocates, will help providers just to all more deeply target efforts at addressing the health inequities fueled by systemic and structural racism. This bill would also require this reporting piece on telehealth for behavioral health services for children and young adults. And I think we all are really familiar with just how telehealth and the expansion of that has been so critical in Maryland's effort to mitigate the spread of COVID-19, but we do lack this key data on how children and young adults are utilizing these services for behavioral health. And then lastly, this piece around additional reporting for voluntary placement agreements or VPAs is really intended to help us better understand why gaps do still remain for young people and their families who are seeking a higher intensity level of care during a mental or behavioral health crisis. The Mental Health Association of Maryland, our Children's Behavioral Health Coalition have both made this a priority bill for us for the 21 session. We're really eager to see it pass. We're really excited for Delegate Sample Hughes' continued leadership on this issue and would urge a favorable report on this bill. Thank you so much.
Our pleasure. Our next witness is Ann Geddes. Good afternoon.
Good afternoon. Thank you, Madam Chair and Madam Vice Chair. My name is Ann Geddes. I'm with the Maryland Coalition of Families. MCF helps families with a loved one with a mental health or substance use problem by providing family peer support and navigation services. And I'm hearing strong support of House Bill 1243. As has already been said, in 1218, you passed House Bill 1577, which required the Maryland Department of Health and the Department of Human Services to gather data on the utilization of mental health services and voluntary placement agreements by youth and their families. The data report that resulted from this legislation was incredibly helpful to highlight what needs to be done to improve the system of care for children and youth in Maryland. My written testimony lists some of the important issues that were brought to light in the data reports and actions that were subsequently taken to improve the system of care. While House Bill 1577 was a good start, there are important items that were overlooked. Among the more important of these was the requirement that data about substance use services be collected and reported. It was strictly mental health. We have heard over the last few years that there is very little substance use treatment tailored and available to adolescents. We need data about the availability, capacity, and utilization of substance use treatment services by adolescents and young adults in order to begin to improve that system of care. Also, the current data report has pointed to an overutilization of high-end treatment of residential treatment centers by youth of color. It has become clear that in order to begin to address the issue of disproportionality, all data needs to be broken down by race and ethnicity. House Bill 1243 calls for this. The bill also makes necessary corrections and improvements to language that was used in the 2018 bill. Therefore, we urge a favorable report. Thank you very much.
Our pleasure. Next, we have Stacy Jefferson. Good afternoon.
Good afternoon. Good afternoon, Madam Chairman and Madam Vice Chair and members of the committee. My name is Stacy Jefferson, and I'm here on behalf of Behavioral Health System Baltimore in support of House Bill 1243. Behavioral Health System Baltimore is the nonprofit organization that oversees the services and system of care for mental health and substance use disorder for Baltimore City. And as a member of the Children's Behavioral Health Coalition, we support this bill because the data in this bill will allow us to advocate and target services to address the needs of children and families in Baltimore City. We often hear anecdotally about the need for increased behavioral health services for children and youth, particularly substance use services, residential substance use services. And as my colleagues had expressed, as those services close down, we hear that they are needed, but we also hear that they are underutilized. So this data will help us to really understand and get an accurate picture of the gaps in these services. Also, by disaggregating this data by race and ethnicity, it'll allow us to address the health inequities that we know are in our system, and especially to better serve Baltimore City residents. Also, as we know, telehealth has been expanded, and as we continue to advocate for the use of telehealth services, we want to ensure that we have data to understand how it is being utilized by children and youth. So this expanded data is critical because it'll provide us with, again, a more accurate picture of what's happening in Baltimore City, as well as what's happening in the rest of the state. And so with that, we ask for a favorable report on House Bill 1243.
Thank you for your testimony. Are there any questions for this panel? Seeing none, that concludes the bill hearing on House Bill 1243. Thank you so much. We have our last bill of the day, House Bill 1203, Delegate Belcastro, Certificate of Birth and Marriage Certificates, Issuance of New Certificates, Sex Designation. Delegate Belcastro, good afternoon.
Good afternoon, and it's an honor to present the very last bill of the day. Thank you, Madam Chair, and members of the Health and Government Operations Committee for allowing me the opportunity to be before you today. For the record, I'm Delegate Lisa Belcastro presenting House Bill 1203, Certificates of Birth, Marriage Certificates, Issuance of New Certificates, Sex Designation. The Maryland General Assembly has acted numerous times in the past to expand access to identity documents for transgender individuals. In 2015, we passed legislation instructing the Department of Health to issue new as opposed to amended birth certificates for transgender individuals born in Maryland. In 2019, we passed legislation enabling Marylanders to access driver's license that accurately reflect their gender identity. This bill seeks to expand on the prior success that we've had in Maryland in two specific ways. First, it would allow transgender Marylanders to change their name and/or party designation on their marriage certificate. And two, it would direct MDH to issue a new certificate of birth as opposed to amended when a transgender parent changes their name or the parent designation on their child's birth certificate. In Maryland, we currently have no official standard for issuing new marriage certificates after an individual has transitioned. This absence in the law has led to confusion, not just for transgender Marylanders, but also the county clerks that are being asked to make these changes. Individuals seeking to make these changes on their marriage certificates have been told that it's impossible, or in some cases, and this is the kicker, that they have to get divorced and remarried. Obviously, really problematic. So we're seeking to address that. The second point of the bill, it's important to note that we already require MDH to issue a new birth certificate when a transgender individual changes their name and/or gender marker on their own birth certificate. However, we do not have that same requirement when the same person goes to change their name and gender marker on their child's birth certificate. You'll hear from a constituent of mine in just a moment whose family was impacted by this lapse in the law. We have a couple of amendments, a couple of sponsor amendments that the committee should have in their possession. Amendment number 1 is technical. Amendment number 2 addresses technical changes suggested by the OAG and concerns raised by the county clerks. While the county clerks have submitted unfavorable testimony, which you'll see, they mentioned that we met and that our discussions were productive, and it's true, they were productive. This letter also mentions that through amended language that they believe that the goals of the bill can be achieved. And we seek to do that in these amendments. So in our discussions with the clerks, they shared 3 main concerns. The first main concern involved their ability to update marriage license books due to complexities with legacy systems. The second concern involved the party responsible for issuing marriage licenses should they no longer hold their position. And 3, that third concern involved the effective date of the bill. So we've addressed all these concerns with this amendment by striking the mentioning of marriage license books. We clarified party issuance language, and we've pushed the effective date of the bill back to we pushed the effective date for the marriage license portion of the bill back to 2022, just because they wanted some more time to implement these changes. So in closing, I want to mention that every day we go about our lives and we're faced with situations where we have to present identity documents. Forcing transgender individuals to utilize an accurate identification not only outs them, but puts them in potentially unsafe situations. So by passing HB 1203, we would be protecting trans Marylanders and closing some of the gaps that still remain in Maryland law surrounding identity documents. I want to thank the committee for allowing me to present HB 1203. We respectfully ask for your favorable report. And with that, I'd like to hand it over to my panel, who will provide some important insight on the necessity of the bill.
Thank you, Delegate, for your testimony today. Our next witness is CP Hoffman. Good afternoon.
Hello, CP Hoffman. I am the legal director at Free State Justice, which is Maryland's statewide LGBTQ plus civil rights organization. We represent individuals from Maryland's LGBTQ community on a variety of legal issues affecting their gender identity or sexual orientation. And one of the huge areas that we help people with is updating their identity documents. Over the past decade, Maryland has dramatically expanded the access of transgender individuals to affirming identity documents that reflect their gender identity. But there are, as Delegate Belcastro noted, some gaps that remain. And HB 1203 really tries to fill in some of those gaps that were things that were never really intended to be left out, but just were accidentally left out through prior systems. So I'm just going to talk a little bit about why these documents are so important. When we're talking about like children's birth certificates, that we frequently have to use them to establish parentage, as primary forms of identity when we're taking children to register them for school, when you're applying for health benefits or other benefits through the state. Sometimes when you're traveling, you have to have that birth certificate with you, especially if you're traveling internationally, so that you don't run into like a variety of problems. And if that certificate has a different name than the name that you go by, and that's on your ID, it can be a huge problem for trans individuals. Similarly, we see the same issues with marriage certificates. And again, these come up as identity documents regularly in the context of applying for health insurance benefits and other benefits through work. And we see a lot of situations where people are basically being required to out either themselves or in some cases their partners as trans in order to apply for health insurance. So we strongly ask for a favorable report on HB 1203. Thank you.
Thank you for your testimony. Next, we have Kathleen Connolly. Good afternoon.
Good afternoon. I am here to testify on my personal experience. I may not sound as professional as some of the other witnesses I've heard. So I sent you like 3 pages of my written testimony, which is how I originally reached out to my delegate, and hopefully you have all that to read. I'm not going to go over that again. I'm going to add to it with my own personal story and just kind of try to hit the highlights of what I was writing as far as the importance of birth certificates. I was adopted in 1968 and I did not even have a birth certificate until I was 38 years old. I had a birth registration form that only had my name and my birth date on it. And when I was 38 and tried to get a passport is when I first found out that that would not qualify me for a passport. So then I had to learn about how to get my own birth certificate, which I did. And it was about a week of time and navigation. But when I finally got my birth certificate and saw it for the first time at age 38, it had my adopted parents on there and no one could tell that I had been adopted from that birth certificate. My husband, as I wrote to you in my written testimony, is a trans man. You cannot tell that from his birth certificate. My youngest son was adopted and his story is in my written testimony, and you cannot tell that he was adopted from his birth certificate. And then we get to my daughter, who's 17. She has an amended birth certificate. And this is because her father is trans. And when she was born, there was another problem with her birth certificate. We got it fixed once. And then when my husband transitioned, we had to get it fixed again. And it still lists, it still says it's amended on the face of the birth certificate. So I just think that this bill would help to clarify or to fix her birth certificate. So like everybody else in our family, the birth certificate doesn't have to open the door for questions or problems or discrimination.
Thank you for your testimony. Next we have Rachel Smith. Good afternoon.
After several emails, Rachel's not with us today.
Rachel's not with us today. So are there any any questions for this panel? Delegate Saab.
Thank you, Madam Chairman. I'm sorry, I may have missed when the sponsor mentioned something about the amendments. What did the amendments that she proposed would actually change the bill? I don't see them here on my floor laptop. And what is really like the discrimination part? I'm just trying to understand the bill, like the purpose of it. What are we fixing here?
So the amendments directly, we had a meeting with the county clerks and they did submit testimony unfavorable, but in that meeting with the county clerks, they believe that we can get to a place where they can implement the bill. These amendments directly address the concerns that they raised in that meeting with the county clerk. So, we're going to meet with them again after this and hopefully everything is square and everything is good as the amendments are written now. The amendments should be in your email inbox. I'm sorry that they didn't make it to the floor system, but Melissa did send them out to you. They should be in your email. The last part, what we're trying to fix is that currently in Maryland, you are not able to change your name on your marriage certificate. So we want to make sure we're just trying to close the gaps that exist with identity documents in Maryland. We've already fixed the issue with identity documents in terms of your driver's license and your personal birth certificate, but that we don't extend that right now to the children of trans parents, and we don't extend that to those that are looking to change their marriage certificate after if they've transitioned post-marriage. So that's what the bill is going to address.
So if I may just follow up. So I understand what you're trying to fix, but how does that affect the children by having the name, or are we changing the name or the sex on the birth certificate of
So, okay. So what my constituent, Ms. Keneally was explaining is that her daughter has an amended birth certificate right now. And the reason for that is because her father, who is trans, went to update their birth certificate and change their name. But the daughter was then issued an amended birth certificate because her father changed their name on their birth certificate. Ms. Keneally's husband does not have an amended birth certificate for himself, but his daughter was issued an amended birth certificate when he went to change his name on his own daughter's birth certificate. So again, this is just a gap in the law and that we're looking to close.
So to provide an example,
I'm sorry,
if that might.
I think one question.
You're only allowed one,
right.
one answer.
Right.
One from the one panelist to address.
That's fine, Madam Chairman. I can speak to the sponsor.
Delegate Saab, can I ask you to speak to the sponsor offline, please?
Yes, that's what I was just saying. I will speak to the sponsor offline and answer my last question. Thank you.
Thank you so much, Delegate Saab. I appreciate it. We do have Rachel Smith, I understand now. So Ms. Smith, are you here?
Yes, I am. I'm here. Can you hear me?
Okay, yes.
My apologies. I'm new to Zoom and was waiting in the waiting area, but looks like we've got it fixed. So I'm
Okay,
here.
so you have 2 minutes for your testimony. Welcome to the HGO Committee.
Oh, thank you. Thank you so
You
much.
can get started.
Okay. Thank you so much, Delegate Belcastro, for sponsoring HB 1203. Thank you, committee members who are here today to hear our stories. Honorable delegates, my name is Rachel Renee Smith. I live in District 44. My pronouns are they, them, and she, her. It is a privilege to be speaking here today with you as a member of the trans and non-binary communities. I'm here to represent myself, not any organization. I'm also here to represent my loving wife of 9 years, our 3 beautiful children, and LGBTQ families like ours. I'm here to express my family and community's concern that Maryland law governing marriage licenses presently requires Marylanders like myself who have changed our legal name or gender after we were married to effectively out ourselves as trans every time that we were required to present our marriage license to employers, lawyers, insurance companies, numerous government employees. I would like to share with you a little bit about this. I did share a longer testimony in my written testimony, but I will just kind of skip ahead a little bit on that. It was in 2019 with the full support of my wife and the aid of volunteer lawyers organized through Free State Justice that I finally obtained orders to change my legal name and gender markers after I came out as trans gender. After these changes, I pursued the tedious process of communicating these to so many areas of my life, including changing all of my vital records, my diplomas from my undergrad and graduate schools, Social Security, all 3 children's birth certificates, as well as our insurance policies that protect me and my family, as well as our property and titles with MVA and that sort of thing. Over the past 5 years, I think my wife and I have changed jobs about 4 times with each change of employment, with each annual renewal or change of our employer-based health insurance plans. We were required to submit or resubmit vital records for everyone, in basically requiring this is unsafe for trans people, demoralizing, and sends the message to our state's hardworking families like ours that Maryland is not really open for business.
Okay, thank you. Thank you so much. Are there any questions for this witness? I'm looking. Yes, I have Delegate Bagnall and Delegate Robin Lewis.
Thank you, Madam Chair, and thank you, Ms. Smith, for coming in and sharing your story. I just wanted to ask you, because you spoke briefly about it, but this isn't just an equity issue. There is real potential harm and danger if you can't control your own experience. Is that correct?
I'm not sure I'm understanding your question. Harm and danger in controlling.
In having to out yourself every time that you're presenting a legal document.
Oh, absolutely. Yes. I included some statistics about the risks that trans youth in particular face, just because I have worked with them a lot and spoke about that in previous bill. But absolutely, I think that Free State would be happy to provide you with some of their the risk assessment that they did for the community in regards to those risks. Yeah.
Thank you. Thank you very much, Madam Chair.
Thank you, Delegate.
My pleasure. Delegate Robin Lewis.
Thank you, Madam Chair. Thank you, Delegate Belcastro, for this important bill. I appreciate your panel as well. I was curious to know whether the use of ID has implications in healthcare settings. Your panelists did a great job of talking about the use of vital records in, financial and employment transactions.
Unfortunately, Delegate Lewis, you've cut out on me.
Yeah.
I might pitch
Frozen.
this one.
I think I was frozen. Go ahead.
I would unfortunately need you to repeat the question. I didn't get the full context of it. I'm sorry.
I'm sorry, that was my my internet. My question was, thank you for the bill. I appreciate your panelists. They did a good job of describing the challenges they face when they're using their ID for financial employment transactions. I'd like to know if this bill will have any impact on people's experience of accessing healthcare.
So I'm going to pitch this one over to CP Hoffman to answer. CP, are you there still?
Yes. So to give an example of how this could affect healthcare, there's a lot of situations where people get health insurance through their spouse's employer. And if you don't want to out your partner as trans, you will be less likely to apply for employment-based health insurance for your partner if you're required to present their your marriage certificate with their old name, and that refers to them as, bride or groom or whatever the terminology on that marriage certificate was. And so, there are situations where people are not applying for healthcare that they're eligible for because they don't want to be in a situation where they have to out themselves or their partners. Does that?
So this could actually benefit people and encourage health-seeking behavior. Okay,
yes.
Thank you. Thank you so much. Thanks, Madam.
My pleasure. We have next Delegate Krebs, followed by Delegate Bandari.
Just the point that was just made, we had a bill this morning, I guess, on the floor, and we were told on the floor that this kind of information is not on a husband, wife, or whatever, is not on the marriage certificate. It's just on the application. So I just want to make it clear. Is the person this morning correct, or is this person today correct? Is it on the marriage certificate, or is it just a name?
It would depend on when the marriage certificate was issued. So if it was issued before 2012, it would say, I forget whether the terminology is bride and groom or husband and wife, but it does have a designation of who the gender of the parties in that form. The newer certificates do not have that, but because of how the county clerks currently function, what they do if you get a new certificate, if you go in and you request a new copy of your marriage certificate, is they literally give you a copy of that former certificate that says bride and groom and has the former name on it. They don't currently, without a court order, grant a certificate on the new form with the new name.
That's just still different than we were told this morning, but we'll get it straight. Thank you.
Oh.
Delegate Bandari.
Yeah, thank you, Madam Chair, and thank you, the bill sponsor. I was reading a letter from the Maryland Circuit Court Clerk Association, and they opposed the bill, and they said that they cannot comply with the proposed legislation, this bill, regarding changing information on historical paper records, but moving forward, they are fine. Do you want to comment on that?
So, yeah, Delegate Bandari, thanks for the question. In my testimony, I mentioned all of the amendments of the bill, and the amendments of the bill really are to cater to the county clerks. In that meeting we had, and they mentioned in that letter, how they believe that we can get to a place where this would work. All of these amendments are to address the concerns that were raised by them in that letter, and also in our meeting. Specifically, you mentioned the record books. We've taken out of the bill any mention of record books and legacy systems. And we believe that we've hit on everything, all the issues that they've raised. We're going to continue working with the county clerks to make sure that they're good and on board with this bill.
Thank you.
Any other questions? Delegate Lewis, your hand is up. Did you forget to lower your hand? Delegate Robin Lewis? Okay.
I'm trying, Madam Chair. Thank you for the reminder.
Okay, my pleasure.
It's not going.
It's one. Great. I have one question just for clarification, Delegate Bill Castro. Did you see the letter from the Maryland Department of Health?
I did.
Okay, so they said that they can actually implement the bill in 2022, correct?
Yes.
Okay, thank you very much.
No problem.
Any other questions? Seeing none, this concludes the bill hearing. House Bill 1203. The committee and I would like to thank you for coming and for being with us. We hope you have a wonderful evening. Take care. Bye.